peritoneal tuberculosis. So here the alcoholic liver disease is leading. Okay, we are going forward. So till date we are reading much and much about pathogenesis of liver disease, overfilling theory, underfilling theory, and molecular theories, nitric oxide role and all this. So all these are pathogenesis are related to pathogenesis of cirrhosis of liver. This is not related to the pathogenesis of other ascites. The pathogenesis in other ascites is different from cirrhosis of liver. So when we are talking the pathogenesis of ascites, then we have to assume that it is related to cirrhosis of liver only. So there is a increased hepatic resistance by several mechanisms which causes transudation of fluid in peritoneal cavity. Liver become hard. It become hard due to some disruption, some fibrosis. So hard liver is very difficult to for blood flow, and blood flow is diverted towards peritoneum. Another thing, smooth muscle contractions by activation of stellate cells. That also is a dynamic phenomena. And NOS, nitric oxide synthase, that also causes intrahepatic vasoconstriction. And this causes increased nitric oxide in the systemic circulation. So the splanchnic circulation, there is a vasodilatation. So all the blood, more of the blood is pooling in the splanchnic vasodilatation, and it is perceived by kidneys as a hypovolemia, and there is a activation of RAS system, and there is a retention of water and sodium. So these are the pathogenesis related to cirrhosis only. In other cases of ascites, like tuberculosis, like peritoneal carcinomatosis, like pancreatic ascites, all other ascites, there is a exudation of fluid either by reactive exudation, like in tuberculosis there is a reactivation of peritoneum. We don't found any tubercular bacteria in the ascitic fluid in peritoneum, but there is a proteinaceous fluid that exudes. Similarly, in carcinomatosis, tumor cells, they also contribute to the development of ascites by exuding the protein-rich fluid. The another is pancreatic ascites. There is also high protein fluid that comes into the peritoneal cavity by either by leakage from pancreas or by rupture of pancreatic duct. So we will not go deep into the pathogenesis. We will come more interesting subject, classification of ascites. There are multiple ways of classification of ascites. I have covered only 2-3 which were previously in use, and which are I am going to use the most accurate way how to proceed for the ascites. Previously, when we were doing MDs in 20 years back era, then ascites with anasarca and without anasarca. When the whole system is involved in the body, other system like heart is involved, or there is a loss of protein by kidneys, or in myxedema there is a whole metabolism involved, or filariasis, or by gut there is a loss of protein, and there is a poisoning like epidemic dropsy. These all are conditions are associated with anasarca. It means generalized swelling. And other causes of ascites where anasarca is not there, most common is cirrhosis of liver, other tubercular peritonitis, then few rare causes like Meeks syndrome, acute hepatic veins thrombosis means acute Budd-Chiari syndrome, chylous ascites, there is some rupture of lymphatic channels, or there is some obstruction in this lymphatic channels, and hemoperitoneum. These are the causes without anasarca, but it's not very useful. One more classification we were using in the past is transudative and exudative. This was based only on the quantity of protein in the fluid is less than 3 gram per deciliter or more than 3 gram per deciliter. So it was also not much useful, because this is only classifying in the two categories, transitive and exudative. And my aim of today's topic is, you are going out of this hall with 4 different classes of ascites rather than 2 classes, that is based on SAG. This is the most recent classification, that is based on SAG. SAG is a difference, this is not a ratio. It is a serum albumin and ascites gradient. Gradient means difference. What we do? We calculate serum albumin, we calculate ascitic fluid albumin. Both albumin have to be calculated. So what is the difference? If the difference is more than 1.1, it is high SAG. If it is less than 1.1, it is low SAG. And total protein in the ascitic fluid, if it is more than 2.5 gram%, it is high protein. If it is less than 2.5%, so it is low protein. So we now quadrifurcate, or we are with four categories: high protein, high SAG, high protein, low SAG. Then low protein, high SAG, low protein, low SAG. By this, almost 95% of cases of ascites you can diagnose with very surety, with confidence value more than 90%. Only 5 to 10% remains with either mixed ascites or with there is some glitch in the laboratory data, or your laboratory is not so powerful, so you are confused. Otherwise, if you categorize in 4 categories, so first of all we will discuss on most common cause, that is cirrhosis of liver, and it comes with low protein and high SAG. So you do LFT, you do simple diagnostic ascitic type, and you minus the ascitic fluid albumin with the serum albumin. If it is more than 1.1 and total protein is less than 2.5, now you are 90% sure that you are dealing with a liver cirrhosis ascites. And causes of cirrhosis are a different issue. It may be viral, it may be alcoholic, it may be Budd-Chiari, it may be many more. If it is SAG is low and protein is low, both are low, there is only one diagnosis, and you are very sure that is you are dealing with nephrotic syndrome. You can diagnose on the spot. You are dealing with nephrotic syndrome, you can directly refer the patient to your nephrologist. I am sending a patient with low SAG, low protein ascites, and please confirm the diagnosis. Either you can do urine for protein 24 hours, and you can also diagnose, but you can directly refer the patient to the nephrologist. Now coming with high protein, high SAG, rare category. In this we will found cardiac causes like CHF, constrictive pericarditis, tamponade, early Budd-Chiari syndrome. These are the causes related to heart, which comes in this category. Second most common category comes with high protein, low SAG. That is tuberculosis, malignancy, carcinomatosis, pancreatic ascites. Almost second most common category है, that is high protein, low SAG. So both are reverse. First most common is cirrhosis of liver, that is low protein, high SAG, and here is the reverse. So opposite categories are there, by which you can reach up to the 90% of confidence of diagnosing ascites. So it is very important to classify into 4 categories. So remember SAG. If you are remembering SAG, and protein will come automatically. High protein, low protein. How to manage? All physicians know very well. So diet, diet, diuretics, and drain of this ascites. Salt restriction, high calorie intake, or high protein intake, and limited water intake. Diuretics, spironolactone is the first drug choice. Then other furosemide you have to add. Both combination is to prevent the hypokalemia. One is retaining potassium, one is excreting potassium. So that is a very good combination. Other drugs, amiloride, bumetanide and torsemide, these are also can be used as a substitute and as a availability in the state by state. But the most common combination is spironolactone furosemide. Other than this dietary modification, you have to regulate electrolytes, creatinine, weight, abdominal girth measurement to look for the response of your treatment. There are only few indications in which you have to drain paracentesis, and one is diagnostic paracentesis. One is if patient is having trans ascites, then you have to drain it. And third is refractory to medical treatment, then you have to drain it. If patient is having large umbilical hernia and you are having a risk of strangulation, then you have to drain it. Otherwise, there is not much place of, if there is a resistant or recalcitrant ascites, then TIPS is one indication for this. And peritoneal venous shunt is not in fashion. And this is my last slide. This is a laparoscopic view in which there are two pictures. One is this milky, almost milky colored. This is a chylous ascites, and second is the cirrhotic patient with this straw color ascites. Questions are invited for discussion. Please.
Dr. Gupta,
Yeah.
Since you covered this ascites and the SAG score in making the diagnosis, whether it is a cause. Suppose a patient who is suffering from severe malnutrition and comes with the ascites, then how this SAG score is going to help in the management part?
In hyponatremia, hypoproteinemia.
Yes, severe malnutrition.
Severe starvation, hypoproteinemia, that patient will usually present with anasarca, just like protein losing enteropathy, and that will you have to correct albumin levels for this SAG. If very low albumin level, then you have to divide it to accurately correct this SAG. Otherwise, that will also go into low protein and low SAG.
So how can we differentiate between cirrhotic ascites and ascites due to hepatitis C?
No, hepatitis C is not directly causing ascites. It is through the cirrhosis of liver. Even acute viral hepatitis can present with ascites. So that is secondary to cirrhosis of liver. That is the etiology. Hepatitis C is the etiology of cirrhosis.
Pankaj, two questions. One is that would you recommend to drain and diagnose what kind of fluid and SAG it is in all ascites? Number one.
Yes, of
and
course.
Number two, that when you will drain, in case if already diagnosis is done, when patient is presenting again to you. And third is, many a times it happens that in spite of all tests, we are not able to conclude either it is malignancy, tuberculosis. In that scenario, what should be done?
What are the therapeutic indication? So therapeutic indications are TANS ascites. When there is a cardiorespiratory embarrassment, patient is not
Draining the ascitic fluid.
there is usually no complication, no contraindications, even with the very low platelet counts, even with the very high prothrombin PT-INR, you can do safely this ascitic fluid tapping. But if you are tapping in large volumes, more than 5 to 10 liters, then there are chances of some circulatory changes. But these are not also coming very soon. These are coming after 5 to 7 days. So it's a very safe to do paracentesis.
Okay. Thank you, Pankaj. We'll have other questions at the lunch time, please. Lunch time, sir. Lunch time.
ATT-induced hepatitis varies from 3 to 28% in various studies. One of the studies done by Dr. Devar Bavi, all from Bangalore, has shown an incidence of Delhi up to 58%, which was the leading cause. And Another study done in All India Institute showed that ATT-induced ALF was to the tune of 5.7% of its patients of ALF, but high mortality, up to 70% of mortality was then if ATT-induced ALF happens. So criteria of diagnosis should be very clear whenever we prescribe. If there are no symptoms, then SGOT and SGPT levels more than 5 times the upper limit of normal. If symptoms are present, what are the symptoms? Symptoms of acute hepatitis like severe anorexia, vomiting, right upper quadrant pain, some slightest discoloration of the urine, yellowish discoloration of the eyes. So, and if symptoms are present and if you do LFT, SGOT, SGPT more than 3 times the upper limit of normal and bilirubin more than 2 times the upper limit of normal. And we should rule out other causes of this abnormal LFT like acute viral hepatitis by sending viral markers of A and E, autoimmune hepatitis, and other liver disease by doing an ultrasound upper abdomen to rule out any biliary obstruction. So criteria for diagnosis should be clear. And then incidence, as I am telling that we have seen it is prescribed by every physician, surgeon, super specialist, subspecialist. So quite number of ATT hepatitis are there and we all see that. But the 3 drugs which are most common to cause ATT-induced hepatitis are pyrazinamide being the most hepatotoxic, followed by INH and rifampicin. So pathogenesis, if you see, it's because of 2 things we should keep in mind. One is metabolic idiosyncrasy. So it can happen with the first dose itself because it's an idiosyncratic reaction happening due to accumulation of some metabolites when we consume these drugs. So it can happen with the first dose of ATT also. And then second is a dose dependent phenomena when we consume more than 50 gram per day of any of these hepatotoxic drugs. This may lead to formation of hepatotoxic products which will lead to DILI. So if we see INH metabolism in liver, it gets acetylated to acetyl INH and then it gets hydrolyzed into acetyl hydrazine. Other pathway is that first it may get hydrolyzed to hydrazine, which is hepatotoxic, then again acetylation may happen, then acetyl hydrazine, and then it further goes acetylation and formation of non-hepatotoxic products like diacetyl hydrazine, or it may go oxidation to CYP2 enzyme and then conjugation and excretion. So studies have been done that incidence of INH-induced liver NG appears to be higher with slow acetyl phenotype. So slow acetylators have high concentration of acetyl INH metabolite compared with rapid acetylators. So slow acetylators also have higher blood concentration of INH itself. Then there is rifampicin-induced toxicity. As we all know, rifampicin is an inducer of liver cytochrome 2E1 isoenzyme, and it increases INH-induced toxicity by formation of its toxic metabolite hydrazine. As rifampicin also increases the metabolism of INH to isonicotinic acid in tissues, which is also a hepatotoxic product. And the plasma half-life of acetyl hydrazine is shortened by rifampicin, and acyl hydrazine is quickly converted to its active metabolite, which again causes liver necrosis. So rifampicin causes toxicity basically because of inducing the metabolism of INH. And then pyrazinamide-induced hepatitis in the liver. Pyrazinamide is first converted to pyrazinonic acid by amidase enzyme, and then 5-hydroxypyrazinonic acid by xanthine oxidase enzyme. So these 2 are hepatotoxic metabolites. So what are the clinical presentation? Clinical presentation, 20% of the time it will be asymptomatic transaminitis. So if it's 2 to 3 times and patient is asymptomatic, then we should continue the ATT. We should not stop it. But if it's more than 5 times and he's asymptomatic, then we should stop the drug immediately. He's falling into the category of ATT DILI. If it's clinically symptomatic, then more than 2 times elevation also we should consider a clinical hepatitis. And some patient may present with increase in INR, ascites, encephalopathy after starting ATT, and they fall into the category of ATT liver failure, which has a very high mortality, and we should be cautious of this presentation. So what are the risk factors? Risk factors very simple, related to oxidative stress, age, sex, malnutrition, pre-existing liver disease, any genetic polymorphisms in drug metabolic enzymes. So these are the risk factors. If we consider exact cause is not known, but there is interaction between genetic, host and environment factors that contribute to the development of TB Delhi. So age, if we see, studies have shown more than 35 years, there are 4 times increased risk of TB Delhi. And if we see, female gender is a positive predictor of more severe liver disease. If we see the organ cavitary disease, multibacillary tuberculosis and extrapulmonary organ involvement is associated with increased risk of TB Delhi. Malnutrition study has been done which has shown an albumin less than 3.5 gram associated with malnutrition has 3-fold higher risk of developing TB Delhi. Alcoholism, because it leads to malnutrition and undepleted glutathione stores, it can lead to, alcoholics are more prone for tuberculosis Delhi. Then hepatitis B and hepatitis C also 4 to 5 times more prone for tuberculosis Delhi. So they have studied that Chang and associate did not find a link between dosing schedule and hepatotoxicity. Some genetic polymorphism in some enzymes are there, like N-acetyl transferase 2 enzyme, CYP2E1 enzyme, then glutathione S transferase metabolizes INH liver. And slow acetylase, as I have told you, lacking NAT2 activity are uniformly associated with TB Delhi. And some polymorphism in DRA polymorphisms, and they also found some glutathione S transferase M1 null mutation also causes TB Delhi. Role of HLA has also been implicated. So HLA DQB1 presence 0201 and absence of HLA DQA1 102, it is associated, found in studies to be associated with TB. So genetics have also a role to play in tuberculosis Delhi. And TB Delhi is also common in children and it is less frequent than the adults. Basically, the younger the children and use of pyrazinamide has been associated with risk of hepatotoxicity. And usually it is found in whenever they have extensive disease, mainly involving tuberculosis meningitis. And it is, most of the phenomena is here metabolic idiosyncrasy. So how we manage TB Delhi? So prevention, I think you have to give whenever, most important prevention is use ATT only when this indicated. In modern era, in the era of 2022, we should not consider empirical ATT. Some proof should be there, some strong element, as I sir has told, that we have a SAT which is leading high ADA in ascitic fluid. If that is present, and then we should start in tuberculosis preventive ATT. So some strong criteria in everything should be there in every organ to start ATT. I have seen patients, lot of IBS patients been given ATT, leading them to abdominal tuberculosis, so that should not be having. So strong indication should be there to give ATT, then only we should start. Some studies have shown N-acetyl cysteine can be given above 60 years, which can prevent Delhi, but we need more trials on this. It's just a small study. So what is, if TB Delhi happens, what to do? So first step is discontinue all hepatotoxic drugs, INH, rifampicin, pyrazinamide. From the day itself you see the patient, stop drugs immediately. If you have suspicion, you have ordered LFT, then also you ask them to stop unless you see the LFT, because one day of these drugs can also make the difference to the life of the patient, can land them to ALF, can land them to complicated disease. So you should stop that drugs immediately, not decrease the dose, stop immediately. And you should have a second line drugs you should be aware of, which are also very helpful, which is streptomycin or amikacin, ofloxacin, and then combutol can be, which is the first line drugs, can be continued because it's not here. So combutol, amikacin and ofloxacin you should give unless the transaminases returns to less than 2 times the upper limit normal. So this is a flow chart here which I wanted to highlight. Just whenever you start Delhi, counsel the patients about the toxicity of nausea, vomiting, abdominal pain, jaundice or unexplained fatigue. Keep in mind LFT monitoring, especially if age more than 35. You should do every 2 to 4 weeks. AST, ALT, bilirubin can be done. Keep in mind what is the baseline ethanol consumption, any pre-existing hepatotoxic medications he is on, whether he is HIV infection or not, any pre-existing liver disease or not. And if he falls into the category of Delhi, then ALT, as I told, ALT more than 5 times the upper limit, or ALT more than three times with symptoms, then consider ATT Delhi. Exclude other causes of altered LFT if you are strongly suspicious. So once you have considered how to reintroduce of ATT, because ATT also is important therapy for the patient to survive for the cure of the disease. So after ALT returns to less than 2 times of the normal, American Thoracic Society guidelines have said rifampicin to be started at full dose. After 3 to 7 days, you can check again ALT levels. If symptom recurs or ALT recurs, then last drugs to be stopped. So first rifampicin it recommends, then INH to be start, and sometimes people will not re-challenge with pyrazinamide if they 2 drugs they are tolerating, and then with ethambutol and other drugs they can manage tuberculosis. So re-challenge with pyrazinamide may be hazardous if they have tolerated rifampicin and INH. Whereas British Society guidelines, what they recommend is to start sequentially low dose of INH, rifampicin and pyrazinamide, gradually escalate one after one small dose. Like INH, they will start 50 milligram per day. Then every 2 to 3 days, they will escalate up to 300 milligram per day. Similarly, rifampicin, they will start 75 milligram per day, and after every 2 to 3 days, they will increase up to 450 milligram if it's less than 50, or 600 milligram if it's more than 50. Pyrazinamide also start at 250 milligram per day, and gradually increasing dose we can give up to 1.5 gram or 2 gram depending upon the weight. So this is the AIM study, which was a revolutionized study. It is a randomized control trial done in our population, where they have introduced 3 different introduction regime, and it was a randomized. Everyone was arm 1 was H, R and Z at maximum dose, means you restart at maximum dose all the 3 drugs, all the 3 hepatotoxic drugs. Arm 2 was like the American Society, R at maximum dose, H as maximum dose at day 8 and Z at maximum dose at day 15, which usually American guidelines are there. Arm 3 was like British, like H as dose of 100 milligram per day, then maximum dose at day 4, R at days of 150 milligram per day, then at day maximum dose. So very interesting results. Around 237 patients were taken, and then following randomized into 3 arms, 58 patients, 59 patients and 58 patients in arm 3. And all the patients had similar instance of recurrence of Delhi. So this was a landmark trial which revolutionized our management of TB, and you can restart simultaneously or conservatively, it doesn't make a difference. So just to summarize, ATT Delhi is very common in India. Genetic factors may play a role. So which patients can have, we really don't know. Genetics, we don't know of the patients. Clinical criteria and presentations are clear. We should rule out obstruction and other causes of abnormal abnormal LFT. And we should stop first-line hepatotoxicity at earliest is a key, because one additional dose can also make a difference. And we should have a plan of reintroduction of hepatotoxicity. That should also be clear in our mind with close monitoring of LFT. Thank you.
So, Gaurav, do you recommend that we should look for LFT in all patients before starting AKT? In all patients, should we do an LFT?
So baseline LFT, Yogesh, I think it should be done, because it can give an idea whether patient is having subsequently another NASH is there or not, and we should have a basis, because if further he tells us, we should have it rises to the previous value. So baseline LFT should be there.
Should be done.
Sir, to my best knowledge, nothing except isoniazide penetrates the caseating material. And if we are only depending upon the secondary line of treatment, then how the TB will be cured?
Sir, that's what we should wait until the LFT reduces to less than 2 times the upper limit of Lomer. So you have the SGPT reduces to less than 2 times the upper limit of Lomer, then we should start. As I told, we can start all the drugs simultaneously, or one after the other we can start. So that is the time for 1 or 2 months you have to stick to second line drugs. But by the time your LFT improves less than 2 times the upper limit of normal, then you can start INH also.
Sir, in samples, after the baseline LFT, when earliest should be the LFT repeated in the patients who are on anti-tuberculous drug to see the idiosyncratic or dose-related effect?
So that's what you should counsel the patients regarding the symptoms very promptly. If he's totally asymptomatic and none of the high-risk factors, he's not alcoholic, he's not taking any hepatotoxic drugs, he's less than 35, then no need to repeat LFT also. But if all these factors are there, any of the high risk factor, any symptoms they are saying suggestive of, then every 2 to 4 weeks you should keep a high risk patient, you should keep 2 to 4 weeks. And they have seen that the later the tuberculosis Delhi happens, the poor the outcome.
Sir, and sometimes the patient having a anorexia is persistent, his SGPT is normal, and then time the uric acid is remain high. So we stop the pyrazinamide or continues with
So what you are saying is bilirubin only high and
the bilirubin is normal and SGPT is normal, but patient is still persistent anorexia and all this complaint. At this time uric acid is remain high. Then we stop the pyrazinamide or continue the...
No, sir. Then actually we should, that is not due to tuberculosis drugs. So we should give PPI, prokinetics, counsel the patient, he may be stressed. So if LFT is normal, then we should not stop these drugs at all. So that is not the cause. ATT is not the cause for the symptoms of this.
Dr. Chavla,
Sir.
You have not talked about SGOT, SGPT 3 to 5 times. Then what we should do? One. And second, I think pregnant lady, if they are on AKT, you find even 2 times or 3 times, you should stop. Because there is a very high mortality in pregnant ladies.
Yes, yes, absolutely. Pregnant lady, we should be very generous and we should stop. And if symptoms are there, sir, then more than 3 times also we'll take. If there are no symptoms, then more than 5 times.
Sir, you said that SGPT levels and SGOT levels more than 2 times, less than 2 times normal if they come, we have to start.
Yeah, yes, sir.
Start
yes,
there.
yes.
But I see many patients with SGPT level of 50, 60 and with persistent symptoms like nausea, vomiting. Maybe that may be due to ATT or due to this one. But as soon as we stop these drugs, this goes away for nausea, vomiting. So at even the SGPT of 50, 60. So in that case, what should be done?
So, sir, that's what we should give a close monitoring. Some patients will have, as I agree with you with this LFT level also, they may have symptoms. Initially, these drugs, some patients may not tolerate as good as some patients, because some patients are more sensitive, so minor increase in enzymes. So you should, 2 things you can do, but only thing is you should know your patient. If patient is from far off place, he will not turn to you in 3 days, then you should not give. Because according to guidelines, we can give up to 3 times because it is the normal hepatic adaptation. Whenever we give ATT, some amount of SGOT, SGPT will rise. So that is okay, that is not up to 3 times, it's okay. But if symptoms are occurring, then it's not okay. So we can give that, but you should know your patient. If he is a good follower, up to every third day he can show you with SGOT, SGPT trend is going correct, then you can follow. But he is from far from place, he will be not in the follow-up, then you should be a cautious approach.
Okay, thank you.
Sir, excuse me, sir.
Last question, and of course I agree that he has organized the program so nice, 15 minutes, and we are taking more time in questions. And I think we all should restrict there. But this is my last question. Sir, do you think that the hepatitis is related somewhere with IRIS, immune reconstitution inflammatory syndrome?
Yes, sir. Immune reconstitution also does play, as I told, because some genetic factors are there. So whenever we start ATT, some reconstitution happens, especially in patients who are immunocompromised. That may also contribute to the symptoms of TB Delhi.
Sir, any patient with the cirrhosis of liver, especially decompensated cirrhosis of liver, if required AKT, then what to do?
It's a very good question. So in cirrhosis, I will recommend don't give any of the hepatotoxic drugs. Only start with second line drugs and give up to 9 months, 1 year. If you give this first line drugs, they are very high prone for ALF, ACLF and mortality. So according to cirrhosis guidelines, none of these first line drugs are recommended.
So thank you, Gaurav. We'll start with the next session. Excellent coverage, Gaurav. Very nice.
Thank you, sir. Now, we would like to invite Dr. Shreya Budhala, ma'am, Noble Gastro Hospital, to speak on her needle prick in word, how do I manage?
I hope at the back screen is visible now, or you want the light should be dim. It is visible, back side?
Hello, good afternoon. Thank you, Dr. Yogesh, for giving me this opportunity. Today we'll be discussing needle prick in ward. How do I manage? So needle prick injury is a very common thing, and the estimate studies have shown that almost 60 to 70% of healthcare workers once in the lifetime might have experienced needle stick injuries. So what is a needle stick injury? So it's a cutaneous cut, scratch or puncture from a needle contaminated with the patient's blood or body fluid, whether or not the injury drew blood. So the causes include unsafe work practices, failure to dispose properly, and disposal system failures. So the studies have shown that the needle, around 50% of these injuries occur while handling the needles, while 20 to 25% of the injuries occur due to the disposal failure. So the major risk of transmission with needle stick injury is HBsAg, hepatitis B, hepatitis C, and the HIV. Of the more important concern is hepatitis B. So because the seroconversion rates with needle stick injury are to the tune of 60 to 30%, and the conversion rate is more if the patient is HBeAg positive, which indicates high HBV DNA loads, to the tune of 37 to 60%, and it's comparatively lower if the patient is HBeAg negative. With the HCV, the transmission rates are almost 2%, while for the HIV, the transmission rates are only 0.3%. Now, hepatitis B is more important because the virus, the infectivity persists even after 48 to 72 hours the sample has been discarded. While for the HIV, generally after 48 hours, the risk of the infection is low. So the risk of the exposure to the body fluids. So the body fluids which are considered at risk is blood, semen, vaginal secretions, synovial, pleural fluid, peritoneal, pericardial fluid, and any other body fluid which is contaminated with visible blood. While tears, sweat, saliva, sputum, vomitus, they are not considered at risk. So coming to the post-exposure prophylaxis, so the first important step is the immediate first aid. The second step involves the assessment of the risk of transmission. Third is counseling. Fourth is deciding whether the patient requires post-exposure prophylaxis. And the fifth important step is the follow-up. So in the first aid, first of all, most important thing is not to panic. Remove the gloves if appropriate. Wash the exposed site with running water wash the skin with soap and water. And do not use alcohol, betadine, or any other antiseptic. Do not squeeze the wound, or do not put the prick finger into the mouth. In case of exposure to the mucous membranes, irrigate with water or saline. So now coming to the post-exposure prophylaxis of hepatitis B. So there is an important concept of pre-exposure prophylaxis for hepatitis B virus. So HBV vaccination is very effective in preventing seroconversion rates. In case of the vaccine responders, so all healthcare workers should be vaccinated with 3 doses of recombinant hepatitis B vaccine. And it is must that anti-HBs titer should be done in all the healthcare workers 1 to 2 months after the last dose. Because there is a term which is known as the vaccine responders. So if the anti-HBs titers is more than 10, then it indicates that the person is protected from HBsAg. So the protectivity is to the tune of around 95 to 96%. So almost 95% of the healthy infants, 92% of the adults less than 40 years, and 84% of the adults more than 40 years, they develop immunity to after 3 doses of vaccination. So what are the risk factors for the vaccine non-responders? So obesity, old age, smoking, chronic medical conditions, male sex, genetic factors, and immune suppression are the major factors which are responsible for the vaccine non-response. Even in the non-responders, if you give another revaccination with the 3 doses, then it produces response in almost 70 to 80% of the patients. In case of the anti-HBs titer generally declines with the age. So in individuals who are vaccinated at birth, generally after the age of 18 or 20 years, you find the anti-HBs levels less than 10 in majority of the person. So almost only 20% of the persons may have positive anti-HBs titer after 18 years of vaccination. But even in those, they have this memory function of the memory T cells. They generate the immune response whenever they encounter the hepatitis B virus. So in such cases, to assess the vaccine response of a remotely vaccinated healthcare worker, a challenge dose of the vaccine is to be given, and the anti-HBs titer should be measured after 4 weeks of the challenge dose, and it produces response in almost 60 to 95% of the responders. So documented vaccine non-responders are those individuals who do not develop a detectable anti-HBs titer, that is, the titer is less than 10 units, even after 6 doses, that is the 2 full cycles of HBV vaccination. So this is a slide summarizing the post-exposure prophylaxis. So in case of a documented responder, that is, you have the anti-HBs titer which is more than 10, after completed 3 doses of hepatitis B vaccination, you do not require any post-exposure prophylaxis even if the patient is hepatitis B positive. In case of a documented non-responder, that is, even after 6 doses, there is no, the anti-HBs titer is low, then in such cases, only hepatitis B immunoglobulin, 2 doses separated by 1 month should be given for the post-exposure prophylaxis. There is no need for vaccination, hepatitis B vaccination in this case, because as such the patient, the healthcare worker is not going to respond to the vaccine. In case the healthcare worker is vaccinated but the response is unknown after the 3 doses, the first anti-HBs titer of the healthcare worker should be measured. If it's more than 10 units per ml, no action is required. And if it's less than 10 units, then both immunoglobulin plus vaccination should be initiated. In case of an incompletely or unvaccinated healthcare worker, if the source patient is positive, then immunoglobulin plus vaccination is recommended, and if it's negative, nothing needs to be done. So hepatitis B immunoglobulin and hepatitis B vaccine should be administered as soon as possible, and it's of no use if it's given 7 days after the exposure. So the dose of the hepatitis B vaccine, it's generally 1 ml, which is given to the adults, while for the pediatric age group it's 0.5 ml, which is the dosing of around 20 micrograms. Larger doses should be given in the patients who are on hemodialysis to the twice the normal dose for the adults. So hepatitis B immunoglobulin, it provides passive anti-HBs and temporary protection for around 3 to 6 months. And for the post-exposure prophylaxis, it should be used along with the hepatitis B vaccine, and both of them, they can be given simultaneously, but the site has to be different. HIB is used alone in case of the vaccine non-responders. So the standard adult dose is 0.06 ml per kg or 12 international units per kg given intramuscularly. So the routinely available vials, they are either 100 units or 200 units vials they are available. And so based on that, the dose calculation will be 12 units per kg. So which will require almost around 3 to 4 vials of 200 units. For the neonates, 0.5 ml or 100 units should be given intramuscularly, and it is 85 to 95% effective in preventing perinatal transmission, and around 75 to 80% effective in preventing HBV infection post-exposure. So coming to the post-exposure testing for hepatitis B, so the healthcare workers who have anti-HBs less than 10 units or who are unvaccinated or incompletely vaccinated, you should get a baseline HBsAg testing. And after 6 months, HBsAg and total anti-HBc should be repeated. Coming for the post-exposure prophylaxis for hepatitis C. So PEEP is not recommended for hepatitis C. So what are the reasons? Because the transmission is, the risk of transmission is low. chronic hepatitis C is curable, unlike hepatitis B and hepatitis and HIV. And antiviral drugs which are as of now available, they act on the later stages of HCV replication and do not prevent the infection of the hepatitis, hepatocytes. And also the cost of the antivirals is high, and giving it for 4 weeks is not cost effective. So testing for HCV infection following exposure. If the source is positive for anti-HCV, then if the patient is present, then he should be tested for HCV RNA. If HCV RNA is positive, testing in the healthcare workers is indicated. So HCV testing should be done at baseline at 4 to 6 weeks and 6 months after the needle stick injury. And if the healthcare worker is found to be infected at the end of, say, either 6 weeks or 6 months, then the full course of 8 to 12 weeks of the antivirals needs to be given. So coming to the post-exposure prophylaxis for HIV. So the CDC recommends that 3 steps are important in determining whether the person requires post-exposure prophylaxis or not. Step 1 is determining the exposure category. Step 2 is the status of the source, and step 3 is the need for the post-exposure prophylaxis. So the exposure category, whether the material is bloody or bloody fluid, it's blood or other potentially infected material. On the basis of that, if there is a low risk of transmission with the fluid, PEEP is not required. But if there is blood or any other fluid contaminated with blood, then depending upon the type of the exposure, so there are 3 categories. If the exposure is on the intact skin, no PEEP is required. In case of a percutaneous exposure, if it's a superficial scratch or just a subcutaneous injection with the fine needle, then it's an exposure category 2. While if severe deep injuries with large bore needles, then it's an exposure category 3. In case of the mucous membrane, depending upon the volume, whether it's a small volume or a large volume, it's either an exposure category 1 or exposure category 2. So coming to the status, step 2, which is the status of the source. So if the patient is HIV negative, obviously you don't require PEEP, but in case of the HIV positive individuals, if the patient is asymptomatic, is healthy, has low titers of HIV RNA, or which is indicated by high CD4 count, then it's a source category 1. While in case of patient in the advanced state having full-blown AIDS with low CD4 count and high HIV RNA levels, then the HIV, it's a source category of 2. So determining the PEEP recommendation for mild exposure, exposure code 1, and with a healthy person, it's generally not recommended, but you may consider giving PEEP. For exposure code of 2 and 3, as well as in particularly if the patient is symptomatic, then a PEEP is recommended. Even in exposure code 1, if the patient is symptomatic, you need to give PEEP. And it should be given for almost 28 days. So the latest guidelines, NACO guidelines, recommend tenofovir, lamivudine and dolutegravir as the first line regimen for PEEP. If it's not available, then protease inhibitor, that is lopinavir or a ritonavir, can be plus ritonavir combination to be added. In children more than 6 years and weight more than 20 kg, combination of zidovudine plus lamivudine with dolutegravir is the first line. And for children less than 6 years, zidovudine plus lamivudine with lopinavir and ritonavir is indicated. So the first dose of the PEEP should be given within 2 hours preferably, and it's of no importance if you delayed by 72 hours. And duration of PEEP is 28 days. So follow-up in case of HIV. So you require for blood test for complete blood count, creatinine and sugar levels for monitoring the toxicity. On week 6, you require an testing for HIV, which should be repeated at 3 and 6 months. So just a take-home message, always be careful while handling needles and sharps. Immediate first step is very important. All healthcare workers must be fully vaccinated for hepatitis B. and post-vaccination protection must be confirmed by anti-HBs titer more than 10. Post-exposure prophylaxis indicate for hepatitis B indicated for unvaccinated or partially vaccinated, both immunoglobulin along with 3 vaccination, and PEEP for HIV should be started within 72 hours and should be given for 28 days. PEEP for HCV is not recommended, and testing for HIV, HBsAg and HCV at baseline 6 weeks and 6 months is needed. Thank you. Yeah.
Madam, all person fully vaccinated for the hepatitis B vaccine are immune for any injury, needle prick injury or?
No, you need to, that is what is important. People, like we obviously take vaccination, but we do not check our anti-HBs titer 1 month after completion of vaccination, which is very important. Because if the titer is more than 10, it indicates that you are protected, you are a vaccine responder, and only vaccine responders, they will be protected against subsequent injury to hepatitis B.
And what is the time for booster dose of hepatitis B vaccine?
So booster dose, generally the immunity lasts for around 18 to 20 years. So if you have an anti-HC, the titer, anti-HBs titer less than 10, you can get a single dose of the vaccine, and it will result in the anti-HBs titer more than 10 in most of the, almost around 70 to 80% of the individuals. Yes.
Ma'am, patient is hepatitis B positive and healthcare worker is exposed by needle prick. Now we are giving HBIG. So why the vaccine is needed at the time of prick? Patient is already exposed to hepatitis B virus during needle prick.
Yeah.
So immediate vaccine, why it is required?
So it's not, that's what I'm saying, that hepatitis B immunoglobulin is not needed in case of vaccinated healthcare worker, first of all. So you do not need to give in all the persons having a needle prick injury from the hepatitis B patient. So only those who are unvaccinated or who are vaccinated and the titer is not known, you first get the anti-HBs titer. And anti-HBs titer should, if it's less than 10, then you give immunoglobulin and your vaccine. Because the immunoglobulin level, the immunity with it lasts only for 3 to 6 months. Generally, like the last for, it's detectable for 3 to 6 months, but the immunity lasts for only 1 month. So, and obviously, if you are in this profession, you are going to get future pricks. So, hepatitis B vaccination is required to complete the full course of vaccination at the same time.
So that we can give after 2 months or 3 months, because already patient is exposed to that viral load.
Yeah, but there is no point in giving after 3 months. You can give it, say, the next day or after 1 week, yes, you can give it, but not after 1 month, because by the time the hepatitis B immunoglobulin, the activity declines after 1 month. So if you have given the vaccine at the same time or within like 1 or 2 days, by the time this vaccine immunity from the immunoglobulin declines, the body will produce its own immunoglobulins because of this vaccine.
Okay. Thank you.
Right.
So, thank you, Shreya, for a wonderful discussion.
Thank you.
Thank you, ma'am. It's time for a lunch break. I would like to request all to move towards the banquet lobby area. We will resume here at 1:30 sharp.
And based on all sessions, there is a quiz at the end of the PG course with attractive prizes also. So we see you again at 1:30, maybe half an hour from now. There will be a bell ringing at the end of the 30 minutes, so please come into hall when bell starts ringing. Thank you.
Welcome back, everyone. Hope you had a great lunch. Let us resume our conference without wasting the time. I would like to invite Dr. Sameer Padgar sir, Swastik Gastro and Liver Hospital, Gandhinagar, Ahmedabad, to speak on his approach to a patient with malabsorption.
At the outset, I wish to thank Dr. Yogesh for giving me the opportunity to present myself in this postgraduate session. So I'll be speaking upon an approach to a malabsorption. First of all, the definitions of these three entities should be clear. The presence of one thing does not necessarily mean the other thing is present. Like the most common cause of chronic diarrhea in our clinical practice, IBS diarrhea, it does not present with either maldigestion or malabsorption. Second thing, the most common cause of fat malabsorption in our clinical practice, that is steatorrhea in chronic pancreatitis. Hardly it presents with diarrhea. Most of the patients with steatorrhea presents with stool maximum 2 to 3 times in a day. And third thing, patients with celiac disease, Crohn's disease, tuberculosis of the intestine with malabsorption of different nutrients may not present with chronic diarrhea. In fact, many of the patients may have chronic constipation also. Another thing that should be clear is malabsorption usually most of the time presents with pathologies of small bowel rather than colonic pathology, because colon mainly acts as a reservoir of the stool and it helps in concentration of the stool or solidification of the stool by absorbing excess water and electrolytes. So at that time it is important to know the sites of different nutrient absorption along the GI tract, because sometimes deficiency of particular nutrient may give a clue to a particular site of pathology. Coming to the etiologies of malabsorption, if you will open the textbook, it will be very difficult for anyone to remember these etiologies of malabsorption. So it is better for postgraduates to remember it like this. Pathologies affecting from the lumen like Zollinger-Ellison syndrome, bile acid diarrhea, small intestinal bacterial overgrowth, some parasitic infestations and enzyme deficiencies like chronic pancreatitis. Pathologies affecting the brush border of small bowel like particular enzyme deficiencies, most commonly lactase, either genetic or acquired lactase deficiency, and specific transport defects. Third thing, pathologies affecting the enterocyte or intestinal epithelial cells like HIV, cryptosporidia and other autoimmune enteropathies. Coming to the subepithelium, deposition of collagen band can lead to collagenous sprue. Lamina propria diseases like celiac disease, tropical sprue, Whipple's disease, IPSID, and immunodeficiency syndromes like CVID. Diseases affecting submucosa like TB and lymphoma. Diseases affecting muscularis propria layer like amyloid vasculitis and radiation enteritis. Some of the etiologies are transmural through and through, like Crohn's disease, eosinophilic enteritis, vascular ischemia, strictures, resection, short bowel syndrome, diverticula. Diseases affecting lymph nodes are same as submucosa like TB and lymphoma. And last, vascular diseases like congestive enteropathy, cardiac failure, portal hypertension. All these things may lead to malabsorption syndrome. There are few extraluminal causes like endocrine abnormalities, diabetes, thyroid and Addison's disease, hepatic diseases, pancreatic tumors and chronic pancreatitis, and systemic vasculitis. Spectrum of malabsorption in India is slightly different from that is seen in the West. And if few common causes are asked in exam, then I think these are the causes to be listed. Commonest are celiac disease, tropical sprue, TB, Crohn's disease, small intestinal bacterial overgrowth, parasitic infestations, IPSID and immunodeficiency states like selective IgA deficiency or common variable immunodeficiency. Now, coming to the clinical approach, how one should approach the patients with malabsorption particularly. So, first of all, the thing is we should take detailed history and examination, which should not miss past history, family history, drug history, diet history, obstetric gynec history, and history of any addiction like alcohol. In history, we should give particular emphasis to the features which are particular to macronutrient or micronutrient deficiency, and second thing, features which are particularly we are suspecting of a particular chronic disease causing malabsorption. Once we have taken good detailed history, then initially we should do test to document the malabsorption syndrome. So for that there are some basic blood and stool test which will provide emphasis that yes, this patient is having this particular micronutrient or macronutrient deficiency. Once we have documented the disease, then our job is to put the differential diagnosis, one or two most probable diagnoses, and that can be done by some specialized blood and stool tests, GI imaging, upper GI endoscopy and ileocolonoscopy. Some of the cases may require further testing in specialized centers. So we all know the sign and symptoms of macro and micronutrient deficiencies. So that I will not be talking, but these things should be clear. Patients with fat malabsorption presents with steatorrhea, weight loss and fat soluble vitamin deficiencies. Patient with protein malabsorption may present with foul smelling stool and excess foul smelling gas, edema, anasarca, ascites, muscle wasting, etc. And patients who are having carbohydrate malabsorption may present with diarrhea with bloating and borborygmy, that is excessive rumbling noise in the abdomen, milk intolerance and perianal pruritus. Now if we see, fat and protein malabsorption hardly causes diarrhea. So we have taken history of particular nutrient deficiency. After that, whichever malabsorption syndrome disease we are suspecting 3 or 4, we should take detailed history of that particular disease, like amyloid, that is macroglossia or renal disease or cardiac disease, carcinoid flush, cardiac murmurs, celiac disease and Crohn's disease, various extraintestinal and hepatic manifestation of celiac and Crohn's. And history of diabetes and thyroid is also important, and history of recurrent GI respiratory skin infections in patients with suspected immunodeficiency syndromes. Similarly, in patients with lymphoma, lymph nodes, abdominal mass, B symptoms of lymphoma, in patients with parasitic infections or tropical sprue, history of travel to the endemic area or history of patients staying in the endemic area. In patients with suspected small intestinal bacterial overgrowth, history of previous surgery or motility abnormalities, history of small bowel diverticula and strictures. Then for tuberculosis, I think we all know what are the symptoms and what to know, what to ask in past history. And in Zellinger-Ellison syndrome, history of peptic ulcer, which are particularly refractory to PPI or H2RA antagonist therapy. Now, once we have taken good detailed history, then initially we should do some blood and stool tests to document the presence of malabsorption. Now, these common tests include complete hemogram, including HCT, mean corpuscular volume is important, MCH is important, total leukocyte count, because lymphocytes, eosinophils, they are also a marker of nutrients, platelet count and peripheral smear examination. Coming to the biochemistry, liver biochemistry, renal biochemistry, lipid profiles, low cholesterol, low triglycerides, then anemia profile, serum iron, ferritin, TIBC, vitamin B12 and folic acid levels. Then calcium, phosphorus, magnesium, zinc, vitamin D levels, and in suspected cases, different immunoglobulin levels. In stool test, we all see routine stool examination along with pH. If stool pH is low, then it can be because of carbohydrate malabsorption. Then stool fat analysis, fecal elastase and fecal chymotrypsin for patients with suspected fat malabsorption. For particular diseases, there might be some laboratory tests which may point to a particular etiology of malabsorption, like whole bodies in celiac disease, IBD, platelets may be high in IBD and iron deficiency anemia, WBC count and differential count like eosinophilic gastroenteritis patients may have high eosinophilic count, Similarly, in parasitic diseases, in TB and HIV, lymphocyte counts may be abnormal. ESR and CRP, especially very high ESR in tuberculosis, then also it is helpful in Crohn's disease, lymphoma, etc. Liver biochemical examinations in patients with cirrhosis of liver, portal hypertension, PBC, and even in celiac disease. HIV testing for AIDS, this not be forgotten in any time in patients with chronic diarrhea and malabsorption. ANA testing for connective tissue diseases, immunoglobulin profile, IgA anti-TTG level in celiac disease, and some hormonal assay for endocrine abnormalities. Specialized stool staining for giardia, strongyloids, etc. Stool leukocytes and calprotectin may be helpful in evaluation of patients with inflammatory GI condition, and stool occult blood testing for ulcerative diseases and tumors of the bowel. Sometimes imaging may be helpful if the disease is causing structural abnormalities like plain X-ray abdomen. Calcifications of pancreas may be seen in plain abdominal X-ray. Ultrasound abdominal CT with specific protocols like pancreatic protocols, or CT and MR enterography for structural GI, luminal GI causes, and MRI abdomen. Also, there is a good role of endoscopy, upper GI endoscopy with gastric and small bowel biopsy, and ileocolonoscopy with ileal and colonic biopsy. Now we also have specialized endoscopic facility, which includes magnification endoscopy, chromoendoscopy, or even digital chromoendoscopy like narrowband imaging, which is helpful in further detection of abnormal pathologies. If the diseases are not within the reach of upper GI and colonoscopy, we can further go with video capsule endoscopy, enteroscopy, and take biopsy. And EUS may be helpful in some patients with chronic pancreatitis or pancreatic mass lesions. So, small bowel biopsy may find particular etiologies which are very specific, problems which are very specific to a disease. These problems may be either generally throughout the mucosa of small bowel, or the problems may be patchy, which is involving segments of the small bowel rather than continuously involving. Sometimes abnormality or pathological abnormality may be picked up, but that are non-specific. Other tests which are less commonly useful in approach of malabsorption syndromes are tests for fat malabsorption, like quantitative, semi-quantitative, or qualitative fecal fat estimation, breath test for fat malabsorption, then tests for carbohydrate malabsorption like hydrogen breath test, protein malabsorption test, skilling test for vitamin B12 malabsorption, and tests for small intestinal bacterial overgrowth using hydrogen breath test or jejunal aspirate culture. If I have time, I can present one or two hypothetical case capsules. So, first case, a 16-year-old female presents with GI symptoms in form of bloating, abdominal discomfort, and dyspepsia for last 2 years, which was poorly responsive to over-the-counter PPI medications. There was no diarrhea, weight loss, or GI bleeding. She also had primary amenorrhea, and on examination there was pallor and no other abnormality was there. So this is the laboratory examination. It is showing anemia and low MCV, and iron is 21, ferritin is 8. Ultrasound is normal. I think in these particular cases we have evidence of iron malabsorption. So iron is particularly absorbed from proximal small bowel, that is duodenum and proximal jejunum. So the pathologies which are affecting commonly in our areas are celiac disease, tropical sprue, or sometimes chronic giardia infection, or upper small bowel inflammatory bowel disease. So I think first blood test we should do in this case is IgA TTG along with total IgA. So total IgA in her case was normal and IgA TTG was raised. So we went further with upper GI endoscopy, and this is showing this abnormal findings in proximal duodenum, that is scalloping of the duodenal folds. Biopsy was suggestive of celiac disease, and patient was put on lifelong gluten-free diet. Second case is a 42-year-old male patient with recurrent episodes of periumbilical colicky pain for last 1 year. It was associated with bloating, borborygmy, occasional abdominal distension, and weight loss of 5 kilogram. He had no diarrhea, no overt GI bleeding, fever or vomiting. On examination, he had edema feet, and on abdominal examination, it was soft. Now, in this patient also, laboratory is showing anemia, which is 11.1 hemoglobin. MCV is little bit higher, 101. Albumin is low, 3.1. And iron and B12 both are low. X-ray abdomen and USG is normal. Now, this patient is having symptoms of small bowel disease, and ultrasound is not a good test for a small bowel evaluation. It is very good for hepatobiliary diseases. Then we did fecal calprotectin. It was obviously high, and when we went ahead further with CT enterography, which showed multiple stricture in proximal and mid jejunum and proximal ileum. So possibility of Crohn's disease was there. Now, in these cases, even though pathology is not in the proximal small bowel or terminal ileum, most of the time we first go and do upper GI endoscopy and colonoscopy, because many a times we may find ulcers and which may detect the pathology. So upper GI scopy and colonoscopy was done, it was normal, and then NP grade enteroscopy was planned, and it was showing this ulcerated narrowing in proximal jejunum, and histopathology was consistent with Crohn's disease, and patient was started on induction regimen with steroid and azathioprine. Thank you.
We invite 2 to 3 questions. Samir has covered very nicely. Actually, it is a very vast topic. We can do entire one-day conference on that. So he has given a good description in 15 minutes. Any questions from the audience? I think Samir, you have done a wonderful job.
There is a question, sir.
This calprotectin, fecal calprotectin, what is the importance of this in such type of patients?
Basically, this fecal calprotectin particularly shows that there is an ongoing inflammation in the small bowel or proximal colon. It is not specific for inflammatory bowel disease. It may be high in TB or other inflammatory etiologies, but it is a marker of inflammation.
At least we can differentiate between irritable bowel syndrome.
The patient is having inflammatory diarrhea or malabsorption or non-inflammatory conditions.
So it is only this endoscopy and histopathology that confirms the presence of Crohn's disease.
Yes. So presence of mucosal abnormality, we need to do upper GI or colonoscopy or enteroscopy.
How much important is this barium, double contrast barium enema?
Yes.
Though colonoscopy is there, sometimes the patient is subjected for the barium.
Okay.
Irrespective of doing this colonoscopy. Why?
I think this barium is abnormal in only those conditions in which mucosal abnormality cannot be detected by endoscopy or colonoscopy, like Hirschsprung's disease. So the level of pathology can be nicely demonstrated by barium. In colonoscopy, we cannot see the area of narrowing in Hirschsprung's disease, but if we are doing barium examination or double contrast barium, we can see where we can delineate nicely the area of aganglionic segment. So in these conditions, barium may be helpful. Yes.
Thank you.
Okay. So
Thank you.
Thank you, Samir. Thank you.
Thank you, sir. Now I will invite Dr. Akash Roy, Apollo Multispeciality Hospital, Kolkata, to speak on approach to a case of hepatocellular jaundice.
Very good afternoon to everybody. First of all, I bring regards from Calcutta Apollo Multispeciality Hospitals And I thank the entire team of Noble Gastro Hospital and specifically Dr. Yogesh for this invitation to be here. As over the next about 12 to 15 minutes, I would walk you through to approach to a very commonly encountered problem, that's hepatocellular jaundice. So I would divide my talk into definitions, simplistic algorithms, pattern recognition, history and physicals, stepwise investigations, a few cases, and then summarize it all. So pattern recognition is one of the most important things that's there in hepatology. You have to identify different patterns of liver disease elevations, of bilirubin elevations, of your enzymes elevation. You have to make it uniform to a particular area, and then you have to recognize what those patterns are. And as you would see throughout this talk, this is what would be the take-home thing that would keep on coming back to us again. Before we get started, let's recap our definitions that we have. The normal bilirubin levels ranges to up to 1.1, out of which usually 70% would be indirect. This indirect takes us back to our MBBS times of Van der Waals reactions, where you've got a conjugated fraction and an unconjugated fraction, which simply stands for that you've got conjugated bilirubin, it would be dissolved in water, and you can excrete it through urine, and you'll get your yellowish coloration of urine. Once you have somebody with jaundice, you need to divide it, whether it's conjugated, when your direct fraction goes more than 50%, or if it is predominantly unconjugated, where your indirect fraction would be more than 80%, which you would see in conditions like hemolysis. When you've got somebody with a conjugated jaundice, you again need to identify the patterns. If you've got your ALTs and your ASTs, which are out of proportion to your ALPs, you would call it hepatocellular. If you flip the coin, and if you've got your ALPs that are more, it becomes cholestasis. And when you've got something in between, you'd call it a mixed pattern of injury. And then there are certain specific conditions in which you would only have isolated bilirubin increment where the enzymes are dot normal, which happens in Duane-Johnson syndrome and Brotus syndrome, which are not our points of discussion today. So before knowing what's abnormal, what is a normal ALT for our population? This has been very variably studied over time. When you go back to the old studies that were there, hepatitis C was not there, and many diseases which you had identified included patients with hepatitis C. Then there was NAFLD, where people were taken with NAFLD were considered as normal, but they were actually not normal. So what the current consensus from the American College of Gastroenterology says that you can take it somewhere between 29 to 33 for males, and for females it's 19 to 25. The best study that's there in this is a study from Lee et al., which they had done normal biopsies, biopsy-proven studies in which you do not even have fat, and those cutoffs are 33 and 25. Do we have Indian cutoffs? Indian cutoffs have been there by two studies, one from Dr. Amrapurkar at Mumbai, and then again from Chandigarh, which says the variations between 26 to 30 for males and 19 to 25 for females. So this is the simplistic approach that you can have to any patient with jaundice. When you have somebody with jaundice, you can have three patterns that are there that we discussed: hepatocellular, cholestatic, hemolytic. How do we divide it? You divide it into something called an R value or an R factor, which has been taken out from cases with drug-induced liver injury, which simply is your ALT divided by its upper limit of normal, and your ALP divided by its upper limit of normal. And you divide it into three subgroups. If you've got this value, which is more than 5, you call it hepatocellular. If you've got it less than 2, that's your ALPs are high, you call it cholestatic. And you've got anything between 2 to 5, this would give you mixed. Coming to our session of the topic that's for today is the hepatocellular part of jaundice, which again needs to be divided into whether it's acute or whether it's chronic. So if you have these things, there are various etiologies which can be acute or chronic. In the acute, you've got your common garden variety viral hepatitis, and you've got some atypical viruses like herpes simplex virus, Epstein-Barr virus, and cytomegalovirus. Alcohol can be acute in somebody who has got a recent onset binge presenting with alcoholic hepatitis. You have to look for drugs, herbals, and all sorts of supplements that we will keep on coming back to in the later half of the talk. And then there are other specific disorders like autoimmune hepatitis, acute presentations of Budd-Chiari syndrome, acute presentations of Wilson's disease, pregnancy and its associated disorders. With that, you always have to throw in that a patient has to be, it can be in a situation where there may be sepsis, they can be on TPN, so those things can also be a cause of acute jaundice in a patient who had never had jaundice before. And then what are the chronic etiologies of hepatocellular jaundice? You've got the other flip side of those same hepatitis B and C, which had the chronic presentation, alcohol, you go back to its chronic presentations that are there. Then again, autoimmune hepatitis, which can again last as a chronic disease. So these diseases can present to you both as acute diseases as well as chronic diseases. You can have primary hepatocellular diseases like HCC presenting as jaundice, or you can have metastatic disorders which can also be presenting in jaundice. And last but perhaps the most important, cirrhosis due to any cause in either of its forms can always present as jaundice. So besides this approach to jaundice, as I had said, what we call the pattern recognition, there is another pattern that you need to recognize when you see any patient with jaundice. Whether the patient had initially a normal liver and had an acute insult. When his INR goes up and his bilirubin goes up, we call it acute liver injury. You club that with encephalopathy, you call it acute liver failure. Flip it off with somebody who has had a background damaged liver. You again put an acute insult to that patient, which can be of any sorts. He develops something of ascites, that's a sign of liver failure. He develops jaundice, he may develop or may not develop encephalopathy. Because he had an underlying liver disease, you would call it acute on chronic liver failure. So these are the two cardinal patterns that you need to see whenever you're faced with any patient with hepatocellular jaundice. What's the pattern of bilirubin? What's the pattern of enzyme? And whether this patient had a background liver disease or did not have a background liver disease. So history. As we have been taught from MBBS days, history forms 80% of your diagnosis. So what are your general questions that you're going to ask? What's the demographics? Whether a patient is a male or a female. What age group does that patient belong to? Is it a young female who you're thinking it's autoimmune? If it's an elderly male where you're thinking it can be a malignant infiltration. What is the onset of the disease? Is this the first episode or this pattern of recurrent jaundice has been having over and over again? What are the ancillary symptoms? Was there a prodrome? Was there any history of biliary colic? Was there colitis, which could point you to something called primary sclerosing cholangitis? What are the other things? And does this patient have family history of liver disease? Then you have to understand the exposure history, whether there is injection drug use, unsafe needle practices, history of tattooing, all these need to be taken into account. Blood transfusions today have become safer, but again, you have the baby boomer cohort where you have to go back and ask about prior history of unsafe blood transfusion. Did the patient have any travel to a particular area? In today's world of globalization, they can be traveling out and bringing up an infection which can cause. And in India, we've got specific areas and which tropical febrile syndromes have got their own outbreaks that are there. And whether some patients are there in the locality if there is outbreaks, which you very commonly see with both hepatitis A and hepatitis E. In India, drugs and toxins, with the rampant use of herbal supplements and dietary supplements, you have to keep on going on back asking them what are those things that they have consumed. And lastly, but in liver disease, one of the most important things there, that's alcohol. But alcohol history doesn't stop at just mentioning alcohol. You have to quantify how long the patient has been on alcohol, what type of alcohol, how many pegs per day, because these all have connotations, and whether there's a history of binge intake, whether there is illicit liquor intake. These all are important in alcohol history. Remember a thing, that just presence of alcohol per se does not preclude you to have a viral hepatitis or an autoimmune hepatitis or any other disease. So next to the history comes your second most important, that's your physical exam. Whenever you're going to see a patient, look at holistically. There are non-liver related diseases like malaria, dengue, typhoid, which all can present with acute hepatocellular jaundice. So look for those peripheral signs from head to toe. And then come to your liver specific signs to see whether there are signs of chronic liver disease, whether there is stigmata of chronic liver disease, whether there are specific alcohol related signs. Don't forget the eye to examine for both icterus as well as KF rings in cases of Wilson's disease. And always go back to the heart, because presence of congestive hepatopathy and heart failure in long-standing cases can also present with a similar pattern. So always examine the patient in a holistic viewpoint. So as I had said, that pattern recognition is most important in hepatology. If you go to the guidelines document from ACG, acute hepatocellular jaundice usually have these patterns. You've got a borderline elevation, moderate elevation, severe elevation, and massive elevation. Borderline can be viral hepatitis, hepatitis B, hepatitis C. When you go to moderate or severe elevation, always remember, say somebody is coming to you with the AST, ALT levels in thousands. There are practically 5 differentials that are there. Viral hepatitis, autoimmune hepatitis, drug-induced liver injury, acute Budd-Chiari syndrome, and the last one, which is an exception, which tends to be missed out, is choledocholithiasis. Choledocholithiasis, we classically think this would be obstructive jaundice, but you've got a small stone which impacted it for a very small period of time. You'll have patients coming with sky-high ALTs and ASTs, and within some period of time, you would see them normalizing. The classical history of a colicky pain would be there, but the enzyme pattern doesn't look like a biliary obstruction. Other clues that are there, if you've got alcoholic hepatitis, there is a classical definition for alcoholic hepatitis, where your bilirubin has to be more than 3, your AST to ALT ratio has to be more than 1.5, and you have to have each of those values less than 400. If you get somebody with a 500, 600 ALT, please do not think of alcoholic hepatitis. There may be alcohol in the background, there's something else going on there. If you've got AST greater than ALT in somebody who doesn't consume alcohol, think that this patient might be already going towards cirrhosis. And a specific caveat for Wilson's disease, where you've got ratios between ALPs to bilirubin, because in Wilson's disease you've got very low levels of ALP when it's an acute presentation, and your AST to ALT ratio. When you've got somebody with very high levels, like more than 10,000, these generally don't happen in liver-specific disorders like viral hepatitis, autoimmune hepatitis. These usually are due to either ischemic hepatitis, toxins like mushroom poisoning, where these are very commonly seen in northeast part of India, and rhabdomyolysis. So these are the 3 classical causes where you will see enzymes going more than 10,000, and add to it when non-hepatotropic viruses like dengue. So patterns, as we say, to summarize it, if you've got an AST more than ALT, you can have alcohol, you can have cirrhosis, you can have ischemia, you can have congestion, you can have acute BCS, you can have hepatic artery thrombosis. Now with transplants became more and more common, it's become common. If you've got ALT more than AST, you think of MASH, viral hepatitis, DILI, toxins, metabolic disorders, and don't forget sepsis itself can be a cause. The other non-hepatic causes which we tend to miss out are rhabdo. Somebody who's got a high strenuous exercise comes to you with an enzymes of 1,000 shutting down of the kidneys. You've got cardiac injury, thyroid disorders, macroasthenia, which is hardly seen, and strenuous exercise that we are talking about. And hemolysis per se, if you get isolated hyperbilirubinemia, bilirubins which are 10, out of which 80% is unconjugated, along with the raised AST, think about hemolysis which is going on. So once you're done with this, how do you order the tests? Always remember, common things are always common. Look at the setting of the patient. If there's a patient in the ICU with MDR growing all over the body, and you've got a bilirubin of 12, AST, ALTs of around 200, 300, don't think that the patient is going to have viral hepatitis in the hospital. That's clear-cut sepsis. So look at the setting that it's there. Order simple tests first. Blood count, metabolic screen, common viral infections, hepatitis A, B, and an ultrasound plus minus a Doppler, depending upon what your setting is. If those turn out to be negative, then you start screening for others, like autoimmune hepatitis, your ANAs, your SLAs, your SMAs, immunoglobulins. Look for ferritins, transferrin saturations, where's a caveat. If it's a very acute inflammatory state, ferritin and transferrin saturations really don't help, and hemochromatosis, as it is in India, is almost always not there. Then, if you're still not getting, go back to your history. There has to be something which has been missed, and usually it's a herbal or dietary supplement intake. And even after all this, you don't get a conclusion, you're left with doing a liver biopsy. If somebody has a caveat that if somebody presents with acute liver failure, which we said somebody who has got into encephalopathy or ACLF, be fast to fast track these patients into centers with transplant capabilities. So let's with that come back to a case, and let's start off with a simple case. We've got a 22-year-old male who has got no prior comorbidity. So we are expecting his liver to be normal, history of fever for around 3 days. He noticed gradual yellowish discoloration of the eyes. The fever went down, the jaundice increased. His labs, as you can see, it's a hepatitic pattern. The R is more than 5. The liver seems normal. Only thing that you get is a GB, which is increased echogenicity, and there are some pericholecystic edema. This is frequently labeled as acute cholecystitis. So if you can go back, what is the syndromic diagnosis? Is it acute liver injury, ACLF, or ALF? They are a normal liver, INR is more than 1.5, and there is jaundice. So this is acute liver injury. What test are you going to order? As we said, we order simple tests first. We order a HAV, HEV, hepatitis B. Some would order a HCV. HCV hardly presents with acute jaundice like this, and you get an ultrasound. This case turned out to be a straightforward, simple acute viral hepatitis with self-resolution. Now let's take you through other cases. The first one is a 39-year-old female who again has no comorbidities. She presents with jaundice. Bilirubin is 20. Enzymes are hepatocellular. As you can see, the R is more than 5. Then there is a male who has got an alcohol history. But the alcohol history is only twice a week, about 30 grams a day, and it has been taking for 2 years. And there is a third patient who is 64 years. She's diabetic for 15 years, and she's obese too. All of them have jaundice. All of them have the similar pattern of enzyme elevation. What the fourth case has, which the others don't have, is development of ascites and hepatic encephalopathy. Albumin is borderline for all. Acute inflammatory states, albumin can go down. In the third case, it's more down. INR is elevated for all. You order the simple test first. For the first, all cytologies, viral cytologies are negative. But in that person who was consuming alcohol, his IgM HEV turns out to be positive. If you see his liver on ultrasound, it's a regular liver. There's nothing to suggest of presence of any cirrhosis. So even in the background of alcohol, this patient has acute liver injury, which is due to acute hepatitis E. If you see the first case, this is a classic young female with positive autoimmune markers, raised IgG, no background liver disease, ultrasound liver is normal. You label it as acute liver injury because there is no encephalopathy, only raised INR. You think the diagnosis is acute AIH, you do a biopsy, you get an AIH. But what happened to the third case? Somebody who had got obesity and diabetes and developed ascites. If you see the liver, now the liver is a little irregular. She has developed ascites, which is moderate. So now we have got somebody who has got a background liver disease, has an acute insult, and has decompensated, which classically fits into the definition of acute and chronic liver failure. So the chronic you can think in a background of diabetes and obesity, this is non-alcoholic fatty liver disease. But what happened to the acute? What caused that acute thing to be? It can be seronegative viral hepatitis or sometimes atypical viruses. You go back and redo the history and you found that she has been all the Ayurvedic medicines for the last 6 months. So this is what a common problem that we face in everyday approach to cases of hepatocellular jaundice, is that DILI itself is a diagnosis of exclusion, and this sort of summarizes your entire approach to a case. You have got evidence of injury, see the pattern, what's the R value, whether it's hepatocellular or it's cholestatic. You exclude conditions which are common first, like viral hepatitis, then go on to the other causes, and even include the atypical viruses like CMV, HSV, which we do not generally do, but they do yield up sometimes. Rule out shock, sepsis, toxemia, tropical infections, rule out biliary tract disorders, metabolic disorders. If you still don't go back to the history again, there would be something in the history that's there. And nowadays, for our help, you've got a specific NIH-sponsored websites, that's Liver Talks. You can just send it up, check up any drugs. They are now even doing it for herbals. And you can see the reported events that are there and what's its likelihood of injury. How do you manage? I think we have got entire sessions coming up in the afternoon and the evening on this. So if somebody's got ALF, ACLF, expedite for LT, plasmapheresis, CRRT at centers that are there. Alcohol, hepatitis, if it is mild, only nutrition. If it is severe, you've got steroids plus NAC depending upon the situation and presentations. New evidence with fecal microbiota, transplant and plex. AIH steroids, but be very careful in patients who have ACLF or ALF. Wilson's, again, Plex and LT. Others, everything is supportive and treat the cause. There are whole loads of drugs, SAMe, Silymarin, UDCA, glutathione, pentoxifylline. As of today, no evidence for any one of them. What about N-acetylcysteine, which was classically introduced for paracetamol-associated failures? Now there are 7 studies and a meta-analysis data which has come out of it, which says that initially the earlier meta-analysis said that it does not improve overall survival, but helps in transplant-free survival. But now the updated meta-analysis also shows improvement of overall survival. The studies are, however, heterogeneous. There's a lot of selection bias. Somebody has given NAC orally, not the IV dose that's recommended. And there's an overall lot of heterogeneity that has been there. And the selection criteria are also been different in those studies with NAC, so we need still better randomized controlled trials. So the points to ponder home that we think about any patient who presents with acute hepatocellular jaundice is look for the patterns. What are those patterns that are? Be very systematic in your approach. Look for the entire patient and don't miss the forest for the tree. And lastly, always remember common things are always going to be common. Thank you, everybody.
So this is an era of health checkup. So many patients come with a report and their SGPT level is somewhere around say 70 to 80. And the rest of the work which you do is absolutely normal. No kind of hepatitis, sonography is normal. And they keep on asking us why these enzymes have gone up. And how do you treat these patients, if at all?
So usually 95% of the times, all these turn out to be non-alcoholic fatty liver disease. Now the problem with non-alcoholic fatty liver disease is the SGPT levels per se don't correlate very well with the liver disease activity. Somebody might have an 100 SGPT but have a dot normal liver on biopsy. So when these patients are, I would look at how high the SGPT is, what the platelet count is, calculate scores like the PIP4 or the APRI. These scores have got various cutoff values. If those are in the normal level of the cutoff value, means lower cutoff, I won't do anything for them. I just advise them lifestyle modifications. Now with saroglitazar, be there, and vitamin E, many are on the drugs. But we have to remember that the liver-related mortality for any one of these patients is far less than their cardiovascular or other mortalities. But if somebody falls into that gray zone where of these PIP4 or APRIs, I'll definitely go ahead and do a fibroscan or MR elastography or RFE, whatever it is, see what the degree of fibrosis is, and if there is presence of fibrosis or this dichotomy that there is no fibrosis but the scores are very high, I would then put him into a drug trial and see how he manages about it.
Thank you, Dr. Akash. It was very well narrated. Thank you so much.
Thank you, sir. I would like to invite Dr. Kapil Jambal, sir, AGS Hospital, Gurgaon, to speak on his management of ulcerative colitis, choosing right medicine and knowing correct dose.
Thank you, Yogesh, and it's pleasure to be back at Ahmedabad. So talk is after lunch, so I will try to make it very simple so that you can have attention. And Yogesh told me to make it very simple, so I made it well for physician. Any questions you can ask me. So at the outset, I have no conflict of interest. So you know that ulcerative colitis and Crohn's disease are the two distinctive known as inflammatory bowel diseases. Ulcerative colitis has propensity to infect or involve the colon, whereas Crohn's has, in addition to large bowel, involvement of small bowel. So what disease management should we look for management of IBD? So goals should be that first is to control of symptoms, second is to predict and alter future course of disease, because this is a lifelong disease. These patients are going to have multiple episodes and they have to have a systemic and multiple problem in their further life. And choosing the right treatment approach, whether we should use anti-inflammatory drugs, whether we should go for immunomodulation, whether should we go for immunosuppression, should we use biologics and antibiotics. The right hand side of the picture you see, this is very common, you have seen multiple times, step up versus top down therapy. Step up means we move gradually ascend depending upon the nature of the drugs, whether we start first with antibiotics in Crohn's disease or aminosalicylates in Crohn's versus ulcerative colitis. Then next step is to start using steroids versus azathioprine or mercaptopurines. Third is we use biologicals, and last one is surgery. Whereas in top-down therapy, we just do the reverse, that we start with biologicals and then come down gradually. So I'll be discussing in next slide and telling what patients we should do with which. So when we see the disease pattern, left side is ulcerative colitis, right side is Crohn's disease. So when we see the left side, first picture is proctitis, which is involvement of only part of rectum and distal sigmoid. So this is the common presentation. Second is involvement of left-sided colon, which is known as left-sided colitis. And the third extreme right is the extensive colitis or pancolitis, where the whole colon is involved. So this is the disease morphology of ulcerative colitis, whereas on the right side we see the disease morphology of Crohn's disease. So you see, and the bottom of the graph there is disease activity, and you see the graph is coming up and down. So patient will have a Crohn's disease, will have multiple episodes of disease activity. Then in the course he or she may develop a stricture, fistula, abscess, and 1/3 of the patients may undergo a surgery in lifetime, and then recurrence of disease again and again. So they have to have a very long course of life of the disease, and the disease treatment should be started accordingly. And when we see the symptoms, around 50% of patients of ulcerative colitis will present with proctitis. That means they will have symptoms of rectum involvement, that is, they will have bleeding, which is the most common presentation. They will have tenesmus and urgency because the rectum is not able to hold stool. So that will be symptoms of rectal involvement. In left-sided colitis, in addition to proctitis, they will develop symptoms of abdominal pain and bloating, which is present, and this is present in around 1/3 of patients. And last, and which is least common, is extensive colitis. In addition to these symptoms of left-sided, patients will also develop abdominal generalized symptoms like they will develop fever, myalgia, intestinal disease is very common. And when we go to the right side is a disease manifestation of Crohn's disease. So the first and most common is presentation of luminal narrowing or mucosal thickening. So these patients may present with malabsorption, diarrhea, abdominal pain, and weight loss. Second presentation is obstruction. In these conditions, the lumen becomes narrow, and the patient presents with features of partial bowel obstruction, bloating, postprandial pain, and nausea and vomiting. And the last one is fistula development. In this patient, the patient develops symptoms depending upon the nature and the type of where the fistula is developed. So whether they develop a rectovaginal fistula or they develop a enteroenteric fistulas. So various manifestations, the treatment is different. But the topic today for me is more on ulcerative colitis, so I'll focus on that. So what does treatment of IBD should be? The treatment goals should be when achievement of induction, that is starting of remission, then continuous of patient in remission, that is maintenance, then to normalize bowel function, to maintain nutritional status, and to improve the overall quality of life. This should be our treatment goals when we start treatment in patients of IBD. And when we start treatment in IBD, first, because most of the patients, 50 to 70% will have either a left-sided disease or proctitis, so our first goal should be to start a step-up therapy. So stepwise therapy, first is introduction of 5 aminosalicylic acids or aminosalicylates. Second step should be introduction of glucocorticoids. Third is immunomodulators. Then biological, and last, in some patient, unfortunately, they will require surgery depending upon the severity of disease. So the first and the most common use which you see in your clinical practice is 5 aminosalicylic acids. So the mechanical action is they have a topical anti-inflammatory action because of they inhibit prostaglandins and leukotrienes. They decrease neutrophil chemotaxis, and they also have an antioxidant activity. So by this mechanism, they are not absorbed systemically, but they have more of localized effect. And what are the types of aminosalicylates? You can see that it depends upon what type of bonds they have. So the drugs with azo bonds are sulfasalazine, balasalazide, and olsalazine. When we see another means like asacol, pentasa, and Rovasa, which is available in the market, and the right side shows what type of bond do they have. If they have a bond with sulfapyridine so they are called sulfasalazine. If they have double 5-SR bond, then olasalazine, and they have an inert compound balasalazide, then it's a balasalazide. And there are types of mesalamines, that is Asacol, which has oral delay tablets and relate to distal ileum and colon. Pentasa, which is ethyl cellulose coated tablets, they are released from stomach, small intestine and proximal colon, and other are for rectal uses. So this is a very important picture. You see the distribution of aminosalicylates in patients who present to us. So if we give an oral medication like a mesalamine, so that drug may not reach a rectal part or a left-sided colon. So this in patients who present with predominantly proctitis, so the doctor is prescribing drugs, but he or she is not getting improvement. So this is because the drug doesn't reach rectum. So in such patients, you have to add either a suppository, which is up to 15 to 20 centimeter, or enema or a foam enema, so which may reach up to splenic flexure. So this is very important depending upon where the drug or aminosalicylate work. Second important drugs which are in management of ulcerative colitis are glucocorticoids. So they mechanism of action is inhibition of phospholipase A2. So they also inhibit the gene transcription for nitric oxide synthetase and cyclooxygenase 2, and they inhibit production of inflammatory cytokines. So that preparations are oral, parenteral, as well as rectal. So rectal only hydrocortisone is available, whereas oral is prednisolone versus prednisolone, or we use hydrocortisone for injection. So these are the medications, and the second medication type of steroid we use is budesonide. The benefit of budesonide is that it has very high first pass metabolism, so no systemic side effects. It doesn't suppress adrenals, and very low bioavailability. That's why it can be used for either ulcerative colitis or mild to moderate ileal Crohn's disease. So these are the various studies which have shown. So side effects are for more of with oral corticosteroids. Normally the local or the budesonide doesn't have too much of side effects. And then the next step is for ulcerative colitis and IBD is biological therapy. So what were the factors which we consider before we starting any biologicals in management of ulcerative colitis is what is the route of drug which we are using. Suppose a patient who has a very high malabsorption or involvement of bowel or mucosa, that in that case oral drug may not be useful, and we have to use IV drugs or IM drugs. And to watch speed of response, we required induction therapy. Suppose patient is very sick, in such cases we should not be using oral drugs. In such cases we should be using a parenteral drugs. And what is the role or potential immunogenicity of using biologicals? Then side effects, that includes cancer risk and availability of infusion facility where we are using, and the most important is overall cost. All these biologicals are high costly drugs. So these are the drugs which we use for, I'll be showing a table. So these are just because of lack of time. So this is infliximab, adalimumab, which is commonly available in our country, and sertolizumab was previously available, now not much in use. And this is it's a chimeric. Infliximab is a chimeric which of 25% murine and 75% human. Initially started for rheumatoid arthritis, then had been used in bowel disease. So it's used for mild to moderate to severe Crohn's disease as well as ulcerative colitis, and has many side effects. So because it causes allergic reactions in 10% of patients, delayed hypersensitivity, and we have to pre-medicate patients. So, and it requires a full infusion. So it requires a hospital facility or a daycare facility where it can be given. Second is adalimumab, which is a chimeric of adalimumab of same only, and it is better. So this is the table. What drugs we are using for management of ulcerative colitis? You can see the adalimumab already we have seen. It is anti-TNF used, and it is once in 2 weeks, and it is used for patients who are non-responsive to corticosteroids or anti-TNF drugs. Second is golimumab, which is now coming into market. It is also anti-TNF. It is for our patients who have failed all this biological corticosteroid, then we can use it. Then the new drug which is now available orally is tofacitinib, which is JAK1 inhibitor. It is available in 10 milligram BD dose and orally available, and it is used in patients who have a partial response or non-response to corticosteroids or anti-TNF. Methotrexate has no role in ulcerative colitis. It has role in maintenance of Crohn's disease. Azathioprine, which you have seen, cannot be used for induction of any of the drugs. So it is used for only maintenance of ulcerative colitis and Crohn's disease. So this is one of the. So summary of drugs which we use is, one is 5 amino salicylic acid compounds, which is azo compound sulfasalazine, olasalazine, balasaladide. Balasaladide is used for left-sided colitis, but its availability is very less. Second option which we use for small bowel is Pentasa, Asacor rovasa and Canasa. Glucocorticoids we use normally is prednisolone or budesonide. For injection we use hydrocortisone, and for rectal suppository we use hydrocortisone enema. Immunomodulator which we use methotrexate is for Crohn's disease and not for ulcerative colitis, and purine analogs we use azathioprine and 6-mercaptopurine. The newer drugs which we use is infliximab, adalimumab. So for induction for ulcerative colitis we use aminosalicylates for mild disease. For moderate to severe disease we use corticosteroids, immunosuppressors, infliximab and the newer drugs. For Crohn's disease we use aminosalicylates, corticosteroids, antibiotics and biologics. And for maintenance, I've already told that aminosalicylates can be used for ulcerative colitis, 6-mercaptopurine, methotrexate. Infliximab has been shown, but corticosteroids cannot be used for maintenance. So the purpose of this is that they have to be tapered, steroids have to be tapered, it's only for induction, not for maintenance. So when a patient comes to us with ulcerative colitis, which patient we should subject to step-up therapy, that means slowly we upgrade, and which patient we subject to top-down therapy. So patients who have a high risk, like age, presentation of age is less than 40 years, who are very extensive or pancolitis at presentation, who have a Mayo endoscopy score of 3 or ulcerative colitis activity index score of more than 7, who have a very deep ulcers on endoscopy, who have a low albumin and very high CRP, and who require hospitalization. These patients are sick patients, and we have to segregate and mostly start a top-down therapy in them. Where patients who present with elderly age, more than 40 years, who have proctitis or minimal disease, who have a mild endoscopy score, who have superficial ulcers, they have normal albumin and CRP. These patients or who doesn't require hospitalization, these are the patients who may require a step-up therapy. So we have to titrate our patients and refer accordingly when the patients come to us. So this is one of the busy slides. So this is my last slide. So for IBD disease management, there are two things which are required. One is disease control, that is what symptoms patient has, what medications we can use, and the most important which is upcoming is disease modification. So we have to modify the disease. In disease control we have that patient should be, the clinical response should be achieved, the clinical remission should be achieved. So the biomarkers like CRP or ESR should be normalized, and we should target endoscopic healing and normal growth of mucosa. Whereas how can we modify the disease, that we should try to decrease the patient's disability, patient's quality of life should improve, and patient we should target of preventing disease complications, like patient should not develop stricture, patient should not develop malabsorption, patient should not, if patient is young, the patient should not develop growth retardation and malabsorption. And preventing long-term complication is like patient should not develop like fistulas, strictures or a cancer. So these are our goals, and we have to treat the patient holistically rather than treating as just like disease treatment. With this I thank you, and any questions I will be happy to answer.
Hello. If the disease is mild and limited to rectum, after starting primary therapy, if the patient is responding very well, then how long we have to continue the medicine, or we can stop, or lifelong therapy is required?
So because my topic was only on treatment, so when a patient comes to us, if we see ulcerative colitis natural history of disease, only 15% patients will go into remission. So if first episode and they go into remission, rest 85% patients will have recurrences. So first we have to counsel the patient that he or she may have to take medication for a long time. If you say lifelong, for any patient who's young, he or may not accept. So first you have to understand that patient may not have a disease-free course. Very lucky patients, we have given one course of treatment for 3-6 months, they have gone into remission, they are off treatment and they've lost to follow-up come after 2 years. But it's very rare. It's only 10 to 15% of patients. Mostly patients will have to have, at least if patient has a left-limited or a proctitis, at least a suppository or an enema he or she has to take. You can go away with oral drugs if patient is doing well, start with oral drug as well as rectal drug, and if patient on further follow-up, like the inflammatory markers come down, the disease activity comes down, the clinical parameters improve, and endoscopy also improves. Ideally, the guidelines are now saying that you have to do endoscopy and biopsy to prove that the patient has gone into histological remission also. So ideally should be that. But if patient has all three parameters, like patient clinically has improved, lab-wise CRP, SR has become normal, and the endoscopy also improved. So this patient can be put on a single bedtime dose of either a rectal suppository if only proctitis, or a left-sided disease, only a anemia. So that will suffice. But we have to understand and make patient understand that he or she will have to have a long-term disease.
Thank you, Kapil. It was a very nice talk.
Thank you, sir. I would like to invite Dr. Saumin Shah, sir, Gujarat Gastro Hospital, Surat, to speak on his approach to acute abdominal pain.
Good afternoon. It is nice to hear such a crowd in Saturday around 2:30. Okay, so my topic is approach to acute abdominal pain by residents in emergency or ward. But I have seen there are few residents and many physicians.
No, they are there at the back.
They are there at the back, but there are plenty of physicians also. So what we can do, those who are physicians, just close their eyes and remember their residency days. Okay. So then this lecture will be more delightful for you. Now for the resident doctor, acute abdominal pain, either patient complains in the ward or in the emergency department, it is always an emergency. Suppose some stable patient in your ward suddenly develops acute abdominal pain and screaming in the pain, it automatically becomes emergency. So there is no major difference when patients comes with acute abdominal pain in emergency or your patient in the ward develops acute abdominal pain. So in this case, time is everything. Okay. And you should not lose that time. So goals of the medicine resident is ABC, airway, breathing and circulation. Find the fatal etiologies. If you miss to treat this etiology within few hours, patient may going to die. So first thing first is you have to exclude these etiologies, symptomatic relief to the patients, and call the surgical colleagues. But this becomes a priority number one during residency days. That happened with me also. So any patient with acute abdominal pain, just call surgical colleague. This is not our case. So don't develop this mentality that will impair your clinical judgment in the future. That will affect you in the future. Unless and until I will become a gastroenterologist, okay, this remains untouched for me if I don't entertain acute abdominal pain during my residency days. So this is the first lesson. It is not a surgical case. You are equally responsible for diagnosis and management. Yes, if there is a surgical etiology, your colleague always will be there, either willingly or unwillingly to help you. Okay. So, and another very important thing is nowadays is to give the mental relief to the associated crowd of the relatives. Okay, suppose in emergency, I had very bad experience. So I am resident of Dr. I am still resident of Dr. Solanki sir. Okay, so I had very bad experience in the emergency where lots of the crowds are there and patient had some poisoning issue and something was that. But another very important thing is to give a mental relief of the crowd. Okay, you are a first year, you are a second year, but behave like you are a HOD and you know everything. Okay, that should be firm and without shouting. If you are dealing with your sister or your junior, don't shout, but say, sister, you have to do this. This patient is like that, even you don't know anything. Okay, this is for your own safety. This is for your satisfaction of the relatives can know your case or my relative or patient is in some good hands, some knowledgeable resident guy, even they are studying, but he is able to handle this situation. And this you have to deal in the shortest possible time. So first and the foremost in any emergency, remain calm mentally and be active physically. Okay, don't sedate, just state, examine whatever you can examine, okay, but don't shout.
you have to be loud and firm in orders. Either you are third year resident or first year resident. Okay, so it gives a mental relief to the patient. Your firmness, your calmness will give some sense of security. No, he or she knows everything about this and he or she may handle this very well. Okay. So when you meet a airway breathing circulation with you or anesthesia department or surgical colleague, then first of all we see what are the emergencies, what are the life threats in abdominal pain. It's a abdominal aortic aneurysm, ruptured ectopic pregnancy, perforation of the GI tract and myocardial infarction. Now these four, 5 things, this is common. There are plenty of other etiologies, but these 4, 5 things you have to exclude immediately. You have to diagnose it immediately because you have a window of hardly 2-3 hours for the patients. And even in abdominal aortic aneurysm, you don't have even that window also. Okay, so first try to exclude this etiology. Okay, then you come to the more serious etiology, means they need intervention, but at least you have time for 12 hours, 14 hours for workup, to take in the OT. So that is the appendicitis, ball perforation, diverticulitis, pancreatitis, kidney stone. Okay. And the last is the benign, that is the GERD, gastroenteritis, viral illness, and the least is the functional. Okay, there are functional patients also. You just, their pain threshold is low or just screaming like anything, but and at the end of the day, there is nothing inside. Okay, so this is your last emergency. Okay. Now, abdominal pain, when you see the abdominal pain, it may be a visceral pain, parietal pain and referred pain. Okay, you know the pain, visceral pain is a dull and aching and the site of the origin depending on the embryonic development, foregut, midgut or hindgut. Parietal pain is more severe because it has a pain sensitive fiber and due to the stretching and irritation of parietal peritoneum, it is a more sharper and when the peritoneum is involved in the abdomen, you have a rigidity. Okay. Now, there is a dictum, I forgot in the, we used to read in the residency, the Dalal Dugli. Okay, if any of you are used to read that, there is a dictum for the pain history, I don't know, but you just see O, P, Q, R, S, T. O is onset of the pain, P is the provocating or aggravating factor or progression of the pain, Q is the quality of the pain, R is the radiation, site and timing. But believe me, whatever you hear this, you are not able to apply in emergency. Will you going to remember this mnemonic during that emergency? What is O, what is those? There is a very little time for history while you are dealing with the acute abdominal pain. This is more useful for dealing with the chronic or subacute abdominal pain. But when there is an acute abdominal pain, you have to see the clinical scenario for 3-4 emergencies and then you can reach to the diagnosis. So, where do you feel the pain most? Can you remember how it started? Now these are the few questions at least you can ask within 1-2 minutes. How would you describe the pain? Does it always stay there or does it move? Do you think it is getting better or getting worse? How long you have been had the pain and do you have any other symptoms? Now these are the associated symptoms. This is very important. There are two, I personally feel the important thing is the associated symptoms, short history, and third is the quadrant of pain. Okay, so if the gastrointestinal symptom associated with diarrhea, vomiting, then it may be a gastroenteritis, it associated with the constipation or obstipation, obstruction, it may be a bleeding or distension, means at least you are dealing with the intestine. If there is a hepatobiliary associated with the jaundice, shock, itching, severe fever, you are dealing with the cholangitis. If there may be a dysuria, oliguria, anuria, there may be some kidney stone or a urological problem. If there is a whitish vaginal discharge or some problem, gynecological problem, you may be dealing with the pelvic inflammatory disorder. And this malignancy and everything comes as a, it may present as an acute abdominal pain, it gives you a window to act. So, when patient presented with the shock, these things is to be considered. You go for those patients who require a resuscitation in acute abdominal pain are always emergency. Those require a resuscitation of any form. So, it's acute cholangitis, bowel perforation, bowel infarction, ruptured ectopic pregnancy, ruptured aortic artery aneurysm, splenic rupture, any condition with concurrent massive GI bleed or acute MI. Okay, these are the emergencies.
Now how will you examine acute abdominal pain in emergency or what? The step 1 you go for the vital sign, step 2 is the inspect, and step 3 is the auscultate. But you have to combine step 1, 2, 3 and history taking simultaneously. Okay, you are asking patient, you are putting but what is the difference in the routine? Routine we inspect, palpate, percuss and auscultate. But in this case, you can go for inspect, auscultation and then palpation. Okay, so that can be done together. And if you feel there is a surgical abdomen, okay, surgical abdomen is there is a rigidity or involuntary guarding is there, you think it is a perforation, you can see the sharp tenderness, okay, there is absent bowel soon, and you see the obstructed inguinal or umbilical hernia, you can ask your surgical colleague to take over. You know this quadrant very well, you should know the associated diagnosis along with this. Okay, this is there. So when there is a epigastrium, there are plenty of the etiologies. Okay, but 2-3 common etiologies for the resident doctor you should not miss is when there is a GERD, pancreatitis and acute coronary syndrome. Myocardial infarction, particularly in fieval MI. When there is a left quadrant, you have to more related to the spleen, or what we are missing is the left level of pneumonia. Sometimes you are searching the cores in the abdomen, you go for the abdomen X-ray and you find there is a left-sided pleural effusion. For the central pain usually is a bowel pain. So is the mesenteric ischemia, obstruction, gastroenteritis, or the rarest is the ruptured aortic aneurysm, but this aneurysm patient is usually in the shock. When you are reaching the hypogastrium, it is a cystitis, PID or ectopic pregnancy. Out of this ectopic pregnancy usually missed unless and until you suspect. You have to tell the radiologist that this may be the possibility, and at time what is the most important that you are not going to take is LMP. Okay, usually in emergency you don't remember to ask the LMP of this patient because you don't have minimum time, don't have enough time. In right upper quadrant you can't miss the appendicitis. Diverticulitis is more common on the left side. Okay, so you can't miss the GERD, pancreatitis, okay, this is common, renal colic, and the right upper quadrant are deliberately kept empty because there are plenty of the other etiology, but you can't miss the biliary colic, okay, cholangitis, GB colic, sometimes even acute hepatitis or liver abscess may present as an acute pain. Now, we can't see in each and every one, but what you see is the type of the pain. Suppose patient says you, okay, my pain started, it gradually increased over a period of 1.5 hours and it lasts for the 6 hours. Or I came before, it is so severe that I have to come right now, and it is a right upper quadrant. Possibility you are dealing with the biliary colic. Okay, the pain which is a very sharp but comes and goes within a minute or 5 minutes or 7 minutes. Usually you are dealing with the hollow organ and mostly the intestine. Okay, so renal pain usually radiates from the back toward the loin. Pancreatitis pain is very severe, associated with tenderness and usually in the epigastric region. Okay, acute cholecystitis, you can find the Murphy's sign. I no need to explain what is the Murphy's sign. In acute cholangitis, these are the diagnoses you can't miss. Acute cholangitis, if you go for 12 hours, 24 hours without diagnosis, patient is going definitely develop a multi-organ dysfunction syndrome and die. So, in acute cholangitis, there are the Reynolds triad and Pentad. So, special examination maneuvers, Murphy's sign we know, palpate aorta if time permits, but nowadays I think the investigation is easily available, so it is difficult to palpate aorta or suspect ruptured aneurysm clinically, okay, because it is difficult to do it clinically. So what are the laboratory testing you are advised when they develop a acute abdominal pain? Okay, first of all, if patient, what happens, we have a pamphlet in the residency, okay, CBC, LFT, INR, create, sodium, potassium, and we just stick it and send everything in all 3 vacuity. Okay, so that is okay, but when it is just like when you send an investigation in the private setup, it is just like you are investing a patient's money in a stock market. Okay, then you have to analyze it. When it came back, you have to analyze it. Okay, why should I send it? Okay, so when you are suspecting a woman with the ectopic pregnancy, you have to send HCG. I will take 1 more minute, but always send LFT, hemoglobin, amylase, lipase, and urine routine micro and creatinine. It will just give you something hint toward the possible diagnosis. Ancillary test ECG is mandatory when you are dealing with the severe epigastric pain. I don't know right now what is the status of our hospital, but if X-ray available, go for X-ray, but best I personally feel is still a sonography. If your radiology colleague is cooperative enough to do emergency sonography, go for first sonography. It is non-invasive, easily available. Plain CTs also gives a good information because create may take time around 2-3 hours to come, so contrast CT may not be possible. And in the special population, particularly in elderly, immunocompromised patient, diabetic patient, these all signs symptoms may not be there. So there is a little bit clinical challenge, okay, in this. So only rule in this medicine is there are no rules. But when there is acute abdominal pain, first message, be calm. Second message, for a medicine resident, it is your responsibility to diagnose also. Third message, use tool to exclude the emergency life-threatening condition first. Okay, and ABC is the priority. And fourth, if possible, go for emergency sonography. So learning is not about earning, but a way of learning. Anything resident doctor want to ask?
At least there should be 3-4 questions from the resident doctors, obviously consultant as well.
The condition like ketoacidosis, which may present as acute abdomen. So it is very difficult to diagnose on this invasive part. Simply if there is history and if nothing is there in any quadrant, simply measurement of blood sugar and ketones, that may confirm the presence of ketoacidosis.
Yes.
One. And number two, one condition is acute porphyria. Porphyria is an acute presentation.
Yes.
But in every case, we cannot submit the patient for the urine examination, and that is showing some changes in that.
Yes. You see, all this diabetic ketoacidosis is a different thing, but acute porphyria, it is the diagnosis means you are going to entertain after excluding the major diagnosis. Okay, the patient comes to you first time with acute abdominal pain, and if your first differential diagnosis is acute porphyria, it is very, very rare. Okay, even with the acute porphyria, many porphyria could not be diagnosed even with the urine examination. There are different types of porphyria. Okay, so usually what happens in the acute porphyria, if you see any patient of acute porphyria, they have multiple files, multiple attacks of the abdominal pain, plenty of the investigation has been done, and at the last somebody will ask for the urine for porphobilinogen. Because few porphyria, even urine for porphobilinogen is also negative. Okay, the thing about the diabetic ketoacidosis, any things which has a more symptoms than sign, like mesenteric ischemia, diabetic ketoacidosis, and patient is a diabetic and abdominal pain, okay, what clinically, because RBS is easily available in glucometer, but ketone I think in government setup, when I used to study, is a little bit time taking. Okay, so what you see is a clinical dehydration. That is my point of view. You see the clinically patient is dehydrated because treatment is hydration and insulin. Okay, till the time ketone reports is available, then potassium and insulin, glucose drip and everything is there. But till the time the report is available, what we are going to treat? We are going to treat as sugar. Suppose sugar is 300, 400, give insulin. But patient is clinically dehydrated. And I must feel each and every resident should know how to measure the IVC. This is a very useful tool, and I think it is a very, considering it's a cheap and non-invasive, and government means who are the authorities are there, should at least put in that machine that we can see the IVC in the ICU. At my time, it was not there in ICU. Okay, but it is a great implication if there is a ward or not. In ward, if it is there, you can just see the IVC. If it is a collapsing, whatever the etiology, you just resuscitate the patient, unless and until you feel it's a cardiac etiology. So diabetic ketoacidosis, and second important thing is ABGA. If you go for urgent ABGA, okay, you may also get some hint of the acidosis. Okay, so till the time ketone report is not available, patient is known case of diabetes and left the treatment, you treat with the vigorous hydration if cardiac function permits you, and insulin till the time ketone report is available. Then you can treat as a routine diabetic ketoacidosis protocol.
Saying the same thing, last month in November only, surgeon father and pathologist mother, 13-14-year boy, had a weight loss only, and then vague abdominal pain, investigated completely, including sonography, X-ray, and 10-14 days are left, and then they discussed with some physician, he said, get the sugar done, it was 400. So, first time detected in teenager, I think that should be not in a known case, but when you are dealing with a teenager and likely to have type 1 diabetic, so I think we should keep in mind.
And second, what I feel, because why we are investigating so much? Okay, suppose you go, what is the concept of health checkup? Okay, we go for RBS, we go for SGPT despite the patients are asymptomatic, despite the healthy volunteers are asymptomatic clinically. You may find as a diabetic, you may find SGPT is elevated or underlying NAS is going on. So, you see, clinical presentation may be subtle to the severe. It may be asymptomatic to the extreme. Okay, so that's why in baseline investigation we include the RBS, CBC, SGPT, create. Okay, and so we should include, because sir, what I feel, the vague abdominal pain with certain sugar, usually diabetic ketoacidosis pain is usually severe, but it may present as a mild abdominal pain. So classical case scenario is not there if patient is a mild pain, but weight loss. Any weight loss should be investigated with you have to underlying cause of uncontrolled diabetes, weight loss. So,
I mean to say, pardon? Yeah. The thing is that it is, I am talking of OPD setting,
yes,
not in emergency setting.
OPD
that at our place, what is happening with not only vitals, we have extended vitals, temperature, pulse, blood pressure, respiration. Apart from that, now we also include ECG, SpO2 and RBS for every patient who come to the emergency room. So these things are naturally getting excluded.
Thank you very much.
Very well designed sermon. The talk was very informative.
Thank you, sir. I would like to invite Dr. Venkat Iyer, sir, to speak on his liver abscess management.
So Dr. Venkat Iyer is a senior gastroenterologist and first gastroenterologist in Bhavnagar. He is director and consultant at Sahaj Gastro Hospital and Surgeon Fertility Center. Thank you, Dr. Iyer, for accepting our invitation.
Thanks, Yogesh. We have a wonderful audience and I see a lot of young residents in the crowd. So this is a topic, liver abscess. I thought it is clinically very relevant because we see cases day in and day out, but there are no specific guidelines for treatment of liver abscess. What is available in literature are expert opinions and not much guidelines, but still, 15 minutes is very less for such a vast topic, but I'll try to do justice to that. So we start with a case scenario. We have a 55-year-old male who has a history of significant alcohol abuse, no comorbidities, no surgeries in the past, who presents to the emergency with right upper quadrant pain, fever for the last 1 week, has fever, tachycardia, liver enlargement. He has, on investigation, he has neutrophilic leukocytosis and mildly altered LFT. And we go for an ultrasound abdomen and this is what we find. So this is basically a typically hypoechoic lesion with rugged margins and your diagnosis is obvious that this is a liver abscess that we are dealing with. Now, why does liver abscess occur? So, we know that the liver is constantly exposed to a low level of bacteremia through the blood flow, through the portal blood flow, because the entire load of the portal blood flow is comprising of all the venous return from the intestine. So, the enteric bacteria are there. So, lot of bacteria, they come through the portal blood flow to the liver. In spite of this fact, liver infections are very rare. The reason being that liver is the largest repository of reticuloendothelial system and is therefore able to cope up with this constant barrage of microorganisms. But when the inoculum exceeds the capacity of the liver for control, infection and abscesses do occur. Now, what is liver abscess? If we try to define it, it's a space occupying lesion caused by infectious organisms. The most common is amoebic liver abscess, which is seen in generally 60% of the patients, and we also see pyogenic liver abscess. In clinical scenario, it is very difficult to differentiate between the two. I will come to that. So generally we end up treating both. Rare presentations are fungal liver abscess, mycobacterial liver abscess, and abscess is due to atypical organisms, but I am not going to go in detail of that. So first let's talk about amoebic liver abscess. So amoebic liver abscess is a space occupying lesion in the liver which is caused by Entamoeba histolytica. Among the extraintestinal manifestations of amoebiasis, amoebic liver abscess is the most common. India is an endemic region, the tropical, particularly the part below the Tropic of Cancer. So that part, it's a tropical disease. So these are the various syndromes associated with Entamoeba histolytica infection. There is intestinal amoebiasis, which can be just asymptomatic cyst parsers, to having acute amoebic colitis, in which the disease can be sometimes mucosal, sometimes transmural, sometimes it can present like an ulcerative colitis. There could be an appendicitis, amoeboma, amoebic stricture, whereas the extraintestinal manifestations, we are going to talk about the amoebic liver abscess. So the age group which that presents is the 20 to 45-year-old age group. Male are more common to have this. The ratio is 7 to 9:1. The most common presentation, we have acute and chronic and but the most common presentation is acute benign presentation of the liver abscess. Usually the liver abscess, amoebic liver abscess, is single and it's found in the right lobe of the liver. The risk factors: alcoholism, malignancy, HIV, malnutrition, corticosteroid use, cell-mediated immunity disorders, homosexual activity, recent travel to a tropical region. I will take you back to microbiology, these things that we hate so much during our MBBS, but this is necessary to know this, that the infection is caused by the quadrinucleate cyst that we ingest by contaminated food and water. They go into the intestine, they mature, they exist. From one mature cyst, it divides into 4 nuclei, and these nuclei, they again divide once. So from one cyst there are 8 tropozoites which are produced, and these tropozoites, they then migrate to the large intestine. Then in the large intestine they divide by binary fission, and then they invade the mucosa, and then they pass through the portal system and they are filtered by the liver. So this actually why the genesis of how the hepatic lesion occurs is that the trophozoites are carried as emboli in the radicals of the portal vein, and they get trapped in the capillary system of the liver, and they multiply in large numbers and they cause cytolytic action, and that leads to anemic necrosis of the surrounding liver cells. The main clinical presentations are abdominal pain and fever. Abdominal pain is localized generally to the right upper quadrant. However, if there is a left lobe abscess, then you can have pain in the epigastrium as well. Fever is generally moderate to high grade, and there is sometimes it also presents with fever with rigors and chills. There could be associated anorexia in case of large lesion compressing the diaphragm that could cause cough with or without expectoration. So this is a study which showed the fever and pain abdomen were the most common manifestations. There are some variants. So multiple liver abscesses can occur in 15%. Left lobe abscesses occur in 35%. This lead to longer duration of symptoms. There can be compression symptoms due to IVC obstruction, hepatic flow obstruction. This particularly happens when the caudate lobe is involved. What are the differential diagnoses? Acute hepatitis, acute cholangitis. We had a lecture on pain. So, all the causes of right upper quadrant pain: acute hepatitis, cholangitis, cholecystitis, hydatid liver disease, right lower lobe pneumonia, pancreatitis, appendicitis, and rarely sometimes UTI also can mimic the same symptoms. The blood investigation, you will have a neutrophilic leukocytosis with a high CRP. There may be mild alteration of the LFT. Stool examination is generally not very useful, because by the time liver manifestations develop, the intestinal manifestations are gone. But in 15%, less than 15% cases, you may find amoebic cysts, and then maybe if you find erythrophagocytic trophocytes, then it's a strong indication that, strong in favor of the diagnosis of amoebic liver abscess. Serological markers are available, but if you see studies, even in India, if you see studies from the north and studies from the south, in the north, where liver abscess is not very common, the serology is considered to be very good diagnosis, but if you see in the south, then you see that no one uses serology, because serology, there are a lot of false positives in an endemic region. So false positive in the endemic region, there is a questionable role, and false negative also can occur in serology, because in the early phase of infection, the antibody titers may not have still developed. So what has been suggested? So they say that you use paired tests. So you do one serology and then you can repeat it again after 7 to 10 days. And there are now newer methods which use PCR and gene amplification. However, in the setting of our medical colleges, it is very difficult to have these things done outside a research setting. So more or less, even in clinical practice, we don't rely much on the serology. There was a study on amoebic lectin antigen which was considered to be more than 95% sensitive if prior metronidazole has not been used. This was the study in 2013. However, the imaging, the diagnosis imaging modality choice is USG. There is a peripheral location, rounded shape, poor rim. The sensitivity is 80 to 90%. The problem is that it depends on the person who does the USG. So if he is a good, he looks at the liver properly, suspects a liver abscess, has a good look at the liver from anterior, posterior, all angles, all possible lobes he has seen, then he can diagnose, or sometimes it may get missed. CT scan is very objective, so that operator dependence goes away. So in CT scan you can find a hypodense lesion, and there is always a peripheral enhancement seen when the IV contrast is administered. The sensitivity is very high, 95 to 100%. Gas may be detected in 20% of these patients. Now, image guided aspiration, it is not to be done in every case. I will come to that. But what you get is typically which is called anchovy sauce pus. So pus is a mixture of sloughed blood and it's chocolate brown in color. Smell is offensive. It is bacteriologically sterile. It does not reveal trophocytes anytime. So as such, it is not useful. Why the name anchovy? Because anchovy is a kind of fish, and sauce of anchovy is available for dips. So that is also having a very offensive smell, and the color is similar. So how do we manage? The management is either you use drugs alone, or you use USG guided aspiration with drug. Drug comes in every case, but in certain cases you may have to do aspiration. In some cases you may have to do percutaneous drainage, and very rarely you may require laparotomy. So what is medical therapy? So the most common thing that we use is metronidazole. Two things we have to remember. One is the dose and one is the duration. The dose is 750, recommended dose is 750 milligram thrice daily for 10 days at least. Okay, so the commercially available tablet is 400 milligram. So what I end up giving is 2 tablets thrice daily for 10 days. One should not exceed the 10-day limit, because prolonged course will lead to peripheral neuropathy and some other non-desirable symptoms. There is, of course, that the metallic taste and all that is bad, but if you don't inform the patient that you will have metallic taste, then he will not have. Then alternative is tinidazole, but however we'll see in a study that metronidazole is still the drug of choice. I use metronidazole in all my patients. After treatment of, we should also treat the luminal with a luminal agent to eradicate the cysts. Permomycin and iodoquinol are indicated, but it's not freely available. What we end up using is deloxanide furoate. So criteria for only medical management: non-complicated, no features of imminent rupture, and no compression effect. Metronidazole is a drug of choice. Cure rates are 95%. Most abscesses start healing from the periphery, and mean time to radiologic resolution is 3 to 9 months. So don't keep on looking at the USG follow-up, and if don't worry if the size of the abscess has not completely resolved. It will get smaller, but the time to completely resolve, you don't need to continue giving anti-amoebic agents. Aspiration not routinely indicated. Which cases you should do aspiration? When there is lack of clinical improvement in 48 to 72 hours. If it's a left lobe abscess, why? Because it has a high chance that it will rupture into the pericardium. If it's a very large abscess with impending rupture or compression, how do we know that? That then if you see the rim of the hepatic tissue left, if that is less than 1 centimeter or 10 mm, then you feel that it is likely to rupture. Then a seronegative abscess, that is what I talked about, serology. If amoebic serology is negative and there is an abscess, that means it is probably you are dealing with a pyogenic abscess, and generally most pyogenic abscesses will require some kind of aspiration. There was a Cochrane review on uncomplicated liver abscesses, amoebic liver abscesses, whether it helps or not. So the conclusion was whether you do needle aspiration or only, I'll take 1 minute. So it doesn't matter. Only the pain and tenderness reduces, otherwise resolution is the same. Regarding percutaneous needle aspiration versus percutaneous catheter drainage, they say that percutaneous catheter drainage success of treatment is 100% in one study, whereas 60% with needle aspiration. And you require more sessions of needle aspirations, otherwise it's more or less the same. Surgical drainage now not required usually with this era of interventional radiology. So if there is a complicated liver abscess with rupture into peritoneum, pleura, pericardium, then you may require surgery. If there is a clinical deterioration despite needle aspiration or the catheter drainage, then you may go for surgical drainage. Complications, local pleural effusion, rupture into peritoneum, pericardium and into the biliary tree. Compression to the biliary tree can cause jaundice. Compression to inferior vena cava can cause a syndrome like a Budd-Chiari syndrome. Vascular thrombosis, hepatic vein, portal vein. Then systemic complications. Patient may present to you with a shock, encephalopathy, acute kidney injury and even ARDS. So what are the poor prognostic indicators? The clinical indicators are NCAF and jaundice. If biochemical indicators, serum bilirubin more than 3.5, albumin less than 2. Sonographic, it's a very large abscess, that is more than 5 centimeter diameter, multiple abscess. So these are bad prognostic indicators, and if there is underlying chronic liver disease. So this is the management algorithm. You first see whether liver abscess is pyogenic or, and that differentiation is very difficult to make. If it is no high risk features with abscess less than 5 centimeter, only medicine, only medical management. If it is more than 5 centimeter, then you may require drainage. But if there are no high risk features, you may just avoid a drainage. Just with medical treatment it may improve. And if there is high risk features, you have to do both. And if you require to aspirate, then percutaneous pictal drainage is preferred to percutaneous aspiration. Just few words about pyogenic liver abscesses. These are the causative organisms. The associated condition, biliary or abdominal infection may be present. It is generally due to the hematogenous spread. The predisposing factors are more or less the same, but it has a higher mortality. The diagnosis is more or less simple. It is by imaging and by blood cultures. Principle of management are usually the same. The only difference here is the antibiotic duration. So any intra-abdominal abscess has to be treated for at least 4 to 6 weeks. So it's not 2 to 6, 2 weeks of, generally if it's a pyogenic abscess, 2 weeks of IV antibiotics followed by 4 weeks of oral antibiotics. So these are the antibiotics which we use. We also end up treating amoebic liver abscess, so we give 10-day metronidazole and 6 weeks of antibiotics with include third generation cephalosporins, aminoglycosides or carbapenems. Drainage, if more than 3 centimeter, more than 5 centimeter, then it should be drained. Surgery may be required in certain patients, and source control is very important. If there is a biliary tract obstruction, we relieve the biliary tract. Diverticulitis, we relieve, surgery may be done for that. Poor prognostic factors, advanced age, immunosuppression, and if it is associated with systemic symptoms like shock or acute kidney injury. So this is the most difficult thing to do in clinical practice, to differentiate between amoebic liver abscess versus pyogenic liver abscess. most of the time we end up treating both. Thank you very much. I would like to take any questions.
Dr. Venkat, many times it happens that we treat liver abscess, we even drain it, but again there is recurrence.
Yeah.
So what do you exclude in such patients?
Yeah. So one is you may be dealing with a pyogenic liver abscess in which the source is not controlled. So for example, if we have a diverticulum or a biliary tract infection, if that has not been treated, then repeatedly liver abscess, you need to go to the cause. I'm telling you that most of the time we end up treating for both pyogenic and amoebic. However, the duration is important. Some people give suboptimal dose of anti-amoebic agents. So they may be just giving 400 one tablet thrice daily or something. So the pint of metronidazole which is available, it is 500 milligram. Okay, so one has to give 1.5 pints 8 hourly. So please understand that when you write the dose in your admitted patients, be sure to mention 1.5 pints of metronidazole 8 hourly, and that has to be given, and a total dose of duration should be 10 days.
You have, sir, very well explained the indication for the aspiration, but still I have one doubt. The initially patient is diagnosed on radiological basis that liver abscess amoebic serology is positive. We have started this metronidazole. We are happy to repeat the sonography after 10 days, 14 days. Now initially it was non-liquefied, now it becomes liquefied. The size is around 7 into 6 centimeter. So patient is asymptomatic, all LFT is normal. So is it indication that now?
No, increasing size of the liver abscess, unless the liver margin is less than 1 centimeter, I don't do anything, I'll wait. If the patient is stable, you have to look at the patient clinically. If the patient is stable, wait, don't put the needle in every, but if there is a imminent rupture for a left lobe abscess, or if the rim of the liver, actually, if you want to see the rim of the liver, CT is a better investigation than ultrasound. So if you find the rim of the liver tissue less than 1 centimeter, then it's good to aspirate, and in that case, actually putting a percutaneous drain will be better, because the liver abscess is actually the fluid is very thick. So many a times in the needle it doesn't come, and most of the radiologists, they use maybe a 18 gauge or a 20 gauge needle. So sometimes it doesn't come. So if someone is bold enough to put a 16 gauge or a 14 gauge needle inside, so then that will be better. Or better than that is you try to get an interventional radiologist with you, or a surgeon who will be happy to put image guided percutaneous drain for the patient.
Thank you, sir.
We had come across 2 to 3 patients of diabetes along with the multiple liver abscesses.
Yes.
So in that patient we have started meropenem. So is there any role of amikacin or like that? So
antibiotics, there is no guideline, but it is said that you should get blood cultures and then act accordingly. So the only thing is that duration of antibiotic should be long. So if you are giving meropenem, I would give oral IV meropenem for at least 14 days if you are suspecting that the patient is really very sick.
Amikacin also can be given for
14 days. Yes, sir. It is both.
And then we should put the patient on oral. If we are using
I use generally
tazobactam, then also that should be given for 14 days. 14 days.
Yes.
And then which antibiotic we should switch to?
Pyogenic liver abscesses, they do require treatment for 2 weeks IV, and then oral.
But what happens, many surgeons are stopping antibiotic at 5 days, even though patient is multiple liver. Twice, thrice we had an experience.
So that is what happens. So that's what exactly the question Yogesh was raising, that it recurs. So actually it is not recurring, but actually
it is insufficient duration of
inadequate treatment is what is the problem. So that is the way to go in such patients. And even multiple abscesses can occur with amoebic liver abscess. It's very difficult to differentiate between the two.
Are we using just now imetin, injection imetin when I was resident and in the initial years?
Sir,
injection imetin.
We have not
Dihydroimetin.
We have not used probably because better agents are available.
1 ampule intramuscular for 10 days we are giving.
Sir, I think that is archival. We don't know.
Just for knowing, is there any tuberculous liver abscess in
Yes.
immunocompromised patient?
Yes, yes.
And then how
so
to...
I did mention in my first slide that it is one of the rare manifestations. TB can occur anywhere in the body, that we all know, except hair. So it can occur anywhere in the body.
Should we look for any underlying malignancy in a patient who has recurrent abscess?
Yeah, so rare presentations of amoebic liver abscess, sometimes actually hepatocellular carcinoma may present like that. So it may look like an amoebic liver abscess, but you are actually dealing with a malignancy. So imaging, a good imaging actually helps, particularly a CT.
Dr. Venkat, now these days there are so many diabetic patients, and these people, they eat outside also, and they succumb to chronic, like these amoebiasis, like ek baar diya, achhe ho gaye, वापस हुआ. So, and honestly speaking, the predisposing factors you mentioned, so we really are afraid about them getting into liver abscess. So what would you suggest for them? Anything to prevent liver abscess? No.
So
and cyst pulsars too.
So
how do you eradicate the cyst pulsars?
So I do, in such a patient who has had liver abscess, I would give eradication therapy after completion of the anti-amoebic agents.
And what would that be?
So that will be diloxanate furoate, 500 milligram thrice daily for 10 days.
For 5 days?
10 days.
10 days, okay. And what about these to prevent liver abscess in such patients who are
The
having...
etiology is multifactorial, sir. So even if there are patients who are asymptomatic cyst passers all their life, nothing happens to them. So it also depends on the patient's own immunity. So there is not one way to prevent. We all also eat outside. So it's not a practical advice to give. You can just tell them that you have clean hygienic food. That would be a practical advice. I generally advise my patients that if you are going out, try to eat cooked food rather than using stale food. So that would be a more practical advice.
So thank you, Dr. Venkat. It was very nicely narrated. And now we invite Dr. Shreya Butala for the quiz session. This is a PG quiz, but all can participate. So I invite Dr. Shreya for the same. So you can open this link in your mobile phone to participate in the quiz.
So good afternoon everyone. There are 4 quiz sessions, one quiz after each session. So the link given on the slide, you can log in to start the quiz. There are 15 questions in each session, and the results will be declared tomorrow at the end of the event, at the end of the last quiz.
And this is done intentionally to keep you all till the end.
So once all of you have logged in, we'll be starting the quiz.
I think we can start, Shreya.
Can we start?
Yeah. No?
Or do you need some more time?
So you can log in
Yeah,
again.
we are waiting.
When you open the link, there will be a form appear to just fill your name and details. After that, the question will come.
Shall we start? Okay, question number 1. A 32-year-old woman presents with early satiety, postprandial fullness for past 2 months with epigastric pain, bloating and no benefit with antacids. Ultrasound abdomen shows gallbladder calculi with no changes of cholecystitis. 4-week course of proton pump inhibitor therapy provided no benefit. Upper GI endoscopy is normal, including gastric and duodenal biopsies. What is the most likely diagnosis? A. Celiac disease. B. Irritable bowel syndrome. C. Functional dyspepsia. D. Chronic pancreatitis. Or E. Cholelithiasis. Next question. Which of the following is a risk factor for constipation? Advanced age. B. Male gender. C. High level of education. D. High socioeconomic status. E. White ethnicity. Question number 3. 30-year-old man with 6-year history of pancolitis secondary to ulcerative colitis presented with 2 weeks of increasing rectal bleeding and diarrhea. His disease had previously been in steroid-free remission for 3 years on maintenance dose of mesalamine. He is hemodynamically stable at this visit. In addition to evaluating the progression of disease, what is the most important test to perform? A. Stool testing for Clostridium difficile. B. Testing for H. pylori. C. CT scan abdomen. D. Stool testing for occult blood. E. Upper GI endoscopy. Next question. Which of the following statements is true about gastric antral vascular ectasia? A. GAVE is reversed with H. pylori treatment. B. Mucosal biopsies can differentiate between portal hypertensive gastropathy and GAVE. C. The majority of cases of GAVE are associated with cirrhosis. D. Bleeding from GAVE can be treated with TIPS. E. Bleeding from GAVE can be treated with beta blockers. Next question. 60-year-old man with Barrett's esophagus has been taking omeprazole for the last 15 years. The patient is at greatest risk for which of the following? A. Pneumonia. B. Gastric adenocarcinoma. C. Esophageal squamous cell carcinoma. D. Folic acid deficiency. Or E. Thiamine deficiency. Next question. 50-year-old overweight woman returns to her office for GERD. She had normal upper GI endoscopy and had taken twice daily PPI therapy. What is the next best step in the further management? A. Referral to surgery for anti-reflux surgery. B. Ambulatory reflux pH testing. C. Switch to H2 receptor antagonist therapy. D. Biofeedback. Or E. Referral to bariatric surgery. Next question. Which of the following conditions can cause steatorrhea as the result of deactivation of pancreatic lipase? A. Zollinger-Ellison syndrome. B. High-dose proton pump inhibitor. C. Post-Billroth 1 surgery. D. Small intestinal bacterial overgrowth. Or E. Atrophic gastritis. Next question. When examining a small intestinal biopsy of a patient with celiac disease, which of the following findings is expected to be seen? The disease process that only affects the mucosa. B. Eosinophilic cytoplasm of the enterocytes. C. Increased intraepithelial neutrophils. D. Shorter crypts. Or E. Decreased cellularity of the lamina propria. Next question. All other causes of malabsorption except A. Celiac disease, B. Tropical sprue, C. Post-infectious IBS, and D. CVID. Next question. What is the most appropriate measure in the healthcare worker who is fully vaccinated 10 years ago and a known vaccine responder after needle prick from an HBsAg positive patient? A. Reassurance. B. Hepatitis B immunoglobulin only. C. Recombinant HBV vaccine. D. Hepatitis B immunoglobulin plus recombinant HBV vaccine. Next question. Drug-induced liver injury is defined as A. SGOT or SGPT levels more than 3 times the upper limit of normal. B. SGOT or SGPT levels more than 5 times the upper limit of normal. C. Isolated bilirubin level more than 2 milligram DL. Or D. SGOT SGPT levels more than 3 times the upper limit of normal with bilirubin level less than 2 times the upper limit of normal. It's not the ratio, it's either or. Next question. 6-food elimination diet for eosinophilic esophagitis includes all except A. Wheat, B. Eggs, C. Peanut, and D. Meat. Next question. Patients with enteral predominant H. pylori infection have increased predisposition to which of the following conditions? A. Gastric peptic ulcer disease. B. Barrett's esophagus. C. Duodenal peptic ulcer disease. D. Pangastritis. Or E. Gastric adenocarcinoma. Next question. 45-year-old women with the history of chronic pancreatitis presents with steatorrhea. Deficiency of which of the following micronutrients is more likely to develop in this patient? A. Vitamin A deficiency. B. Vitamin B12. C. Vitamin C. D. Folate. E. biotin. Coming to the last question. Which of the following is true regarding autoimmune pancreatitis type 1? A, it's associated with ulcerative colitis. B, more common in females. C, high serum IgG4 levels. D, histology is characteristic by the presence of neutrophils in medium and small ducts. E, commonly present with cachexia and abdominal pain. We'll be ending the quiz here. We'll just go through the answers. So the first question, the answer was the patient was having functional dyspepsia. Advanced age is a risk factor for constipation. In patients with ulcerative colitis present on steroid-free remission, presenting with increased symptoms, apart from evaluating the progression, you need to check for Clostridium difficile. Question 4. Mucosal biopsies can differentiate between portal hypertensive gastropathy and GAVE. Tips, beta blockers, they are not, do not cause improvement in GAVE. Patients on long-term PPIs, they are associated, have increased risk of pneumonia, as well as Clostridium difficile infections. In patients having GERD refractory to PPI, reflux pH testing is necessary prior to further any therapy. Steatorrhea occurring due to deactivation of pancreatic lipase occurs in Zollinger-Ellison syndrome due to hyperacidity. Celiac disease mainly affects the mucosa and is associated with increased crypts, increased intraepithelial lymphocytes. So post-infectious IBS do not cause malabsorption. In the patient who is vaccinated and a known vaccine responder, nothing needs to be done following an HBsAg prick. So DILI is defined as SGOT or SGPT levels more than 5 times the upper limit of normal, or OTPT levels more than 3 times upper limit of normal with bilirubin more than 2 times the upper limit of normal. So in the 6-food elimination diet, you need to avoid, wheat, eggs, peanut, but not meat. So H. pylori, enteral predominant H. pylori infections is associated with increased acid secretion, which is associated with duodenal peptic ulcer disease. Chronic pancreatitis causing steatorrhea is associated with deficiency of fat-soluble vitamins, resulting in vitamin A deficiency. The rest of them are water-soluble vitamins. And autoimmune pancreatitis is associated with high serum IgG4 levels. Thank you.
Thank you, Dr. Shreya.
Thank you, Shreya ma'am. Now it's time for a tea break.
I would like to request everyone that we should respect time and please have your cup of coffee and tea and come back to the auditorium and have it here only, please.